Good morning. I'm Mike Bryan. I'm on the Adult Education Committee here at Mountain View United Methodist, and I want to welcome you to the Behavioral Health Symposium hosted by Mountain View United Methodist Church. I'd like to thank Pastor Jeff Wakely, if you wouldn't mind standing, Pastor, and who's our pastor, and Clark Becker, the president of our church council, for their unqualified support in putting this together. Before I introduce our keynote speaker, I'd like to go over a couple of housekeeping items. So bathrooms are located at the far end of what we call the Fellowship Center. The space we're in right now is the sanctuary. So as you leave the sanctuary, that big room with the doors at either end that you came in, that's the narthex. And directly across from these center doors here at the back of the sanctuary, there are doors which will take you into the coat room and the narthex, or in the Fellowship Center. And if you go all the way to the back of the Fellowship Center toward the stairs and turn right, that's where the bathroom is. So we've got coffee located out in the narthex, and you're welcome to drink coffee in here. Just use the cups with lids, if you would please. In your binders, you will find a schedule of all the different panel discussions we've got going on today. And we're going to have 2 breaks plus a lunch today. One morning break, an afternoon break, and then lunch provided by Patty Metz and her volunteers here at Mountain View United Methodist Church. So enjoy lunch on us. In the narthex, several local organizations have set up tables with information on resources related to behavioral health issues. Please feel free to visit them either during the breaks or at the end of the day. And we will be discussing topics of kind of a sensitive nature today. So if you need to talk through any feelings that these discussions might provoke, we're blessed to have some experts here to offer you support. So I'm going to ask them to stand up right now, if you guys would. So Barbara Royal is a certified spiritual director. We have Shelley Lassiter-Reed from Good Grief Counseling. Monique Ecker, is that, I have that wrong. We have a fill-in, right? Lynn? Lynn is, and I forgot your last name, Lynn. Lynn Shull. Lynn Shull, and of course, Ashley is the brains behind this whole thing. So they'll be available if at any point during the day you need to seek one of them out and ask for support. I do want to point out that they're not providing counseling, and they're not employed by nor acting on behalf of Mountain View United Methodist Church. So now I would like to welcome James McLaughlin, Community Paramedic Director of Ute Pass Regional Health Service District, who will be introducing our keynote speaker. Thanks, James.
Thank you, Michael. I appreciate you, and thank you to everybody who's here today on an early Saturday morning. It means a lot, and it speaks highly of our community to see so many people that will get up on a Saturday and come and talk about a topic as difficult as behavioral health and substance use disorder challenges. And that's what makes our community so unique and so different from so many others, is at every opportunity for collaboration, this community steps up. You guys, again and again and again, go above and beyond to give back and to show a spirit of just absolutely incredibly powerful giving. You guys have a service person's heart, every single one of you. And I am so thankful to be part of this community. And just one quick thing before I introduce our keynote speakers. I want to acknowledge, again, her name has already been mentioned, but I want to give a special shout out to Ashley. Guys, I can't say enough about how important the work she does is for this community. She herds cats on a daily basis. You know, I am a passionate person, but I am not goal-oriented and I am not task-focused. And she is a taskmaster. She has single-handedly kept the Teller County Mental Health Alliance moving forward in a pretty incredible way. Now, there's other people that do work within that organization, and I don't mean to impede the work that they do in any way, shape, or form, because that's very important. But Ashley is the beating heart that keeps the blood moving within our behavioral health efforts in our community, and we are so very blessed to have her, and I am so incredibly honored to call her a friend. So thank you very much. Now, for our keynote speakers, I will tell you that and I just lost I had notes. There they are. All right. First, I want to talk about Andrea Jones. I've had an opportunity to go to several meetings with this young lady, and it's kind of funny because I like to say I'm a non-recovering talkaholic. The things I'm passionate about, I just can't shut up about. And anybody who's had any opportunity to spend any time with me, including right now, you know that's true. And I feel like I have a partner in crime when we show up to meetings together. And I also feel like we have all the answers. No, but it's so amazing to get in a room with a kindred spirit and to hear somebody else who's as passionate about behavioral health and supporting people in crisis, as Andrea Jones is. In so many ways, it's like looking in a mirror and reflecting my own thoughts and my own passion. And so I really appreciate her, and I think you guys are going to see that spirit here today. And then Kelly Kazi, this is actually our first time meeting today, but I know of you, and your reputation precedes you in a very positive way, and your work is palpable, completely from the very top all the way down to the end user. Your passion for behavioral health and your desire to provide it in a common sense kind of way, in a humanistic approach, is evident. Your fingerprints are visible on every aspect of Colorado Crisis Services. I am so excited to have an opportunity to hear you today, and I know that our community is going to benefit from you. So thank you so much to both of you for coming in on a Saturday. Can everybody give me a round of applause? And let's invite Andrea Jones and Kelly Kazi. Thank you.
Good morning. Thank you for those kind words. I like having my fingerprints on things. It's good. Friends, I'm going to share with you a lot about BHA and the direction we're headed, and have some nice slides. Are you cueing that for me in the back, or do I have a? Oh, good. Okay. Oh, well, got it. Okay. Thank you. Well, I'm Kelly Kazi, and I'm new to BHA, and BHA is pretty new. Have any of you served on our behavioral health task force a few years ago, or the subcommittees? And okay if not, I always just like to give my appreciation for anyone who offered their time and their talents to help get us started as a behavioral health administration. We're the only one in the country that has its own administration devoted to making sure mental health and substance use disorder systems are working for its people. And so I'm really excited about that. I came to BHA From the advocacy, children's side, I was a nonprofit leader for 25 years. I led a youth conservation corps that served Teller County and El Paso County and Pueblo and Canyon City. So I loved being able to come here this morning and be with you all. I also was the leader of the Colorado Children's Campaign, and we did youth advocacy, ran legislation, the voice for children at the state capitol. And when I stepped down from that role to see what was available, the Behavioral Health Administration, of course, was hiring, and this was very exciting to me because I devoted my career to working with young people and advocating for children who needed the kind of behavioral health services that you all have probably experienced or are advocating for, have been part of. They needed that earlier in their lives, and it wasn't there, and it wasn't in a way that was accessible. It was really hard to navigate. So if I had the opportunity to join BHA and make a difference, it's exactly what I wanted to do, and I was fortunate that they then hired me to be able to do it. And I'm going to share with you the direction we're going. We're going to have time today for questions, to hear from you, and we're also going to share how you can continue to be involved and help inform the good work that we're doing. And so I hope we're ready for that. I've asked Andrea to give me the high sign because I want to make sure I'll share what we're doing, but then make sure you all can ask questions and have Andrea and have James be part of helping answer questions and share information too. Does that sound like a good use of our time this morning? All right. Well, James thinks he's passionate. I'm going to rival him, I think, in sharing what we're doing. And I'll share a little bit in that. When I came on to BHA, I was overseeing all of the policy work, and that's what Andrea is part of, as our Deputy Policy Director, our communications and how we help the public know about the work and find what they need. I also led our community engagement team. I'm going to share some of that today because there's a person in your community, lives in El Paso County, that is your bridge to help us, and we are doing some new things. And I also oversee all of our workforce. It's how I knew Clark. We served on the Governor's Workforce Council together. And so I'll share that. I'm changing in my role to lead all of our children and youth work. And so I'm very excited to share what's happening with that. And if there's anything I can't answer, Andrea or James will. And if we can't answer whatever you need, we're going to make sure we get back to you and give you that. So let's kick that off. So the objectives are around, for our time together, just our vision, priorities. I'm going to share with you the timeline to make sure you know the benchmarks that we're hitting so that you all can hold us accountable to the work that we're doing. I'm also going to talk about our engagement model and then, as I mentioned, the engagement opportunities. Yeah, I'm just going to trust you're putting it up behind me since I can't see it. So the important part about our vision and our mission is that it's centered around you. It's centered around you, what you need, what your families need, what your community needs, and everything we're doing at BHA is about trying to center the people in it and be able to give you what you need. And so it's a very tall order, and yet that's what we've been charged to do, and we're very clear that we have the next 2 years while this current administration is in place to get everything in place, to start making some movement, make some changes so that we can sustain the BHA after this administration and into the future. And so everything that you should be hearing about today will be connected to that mission. You should be able to go, yep, that's what they're doing. It's tied to making sure that we're centering you and helping co-create a people-first system. We also are very cognizant that this has been happening for years and years, and people are like, all right, what's going to be different? How's it going to affect me? How am I going to know I can access what we need? And so I'm hoping you'll see that in the slides today and be able to also be involved and help continue to hold us accountable. So I want to share with you just some high-level strategic goals about where we're headed. We're very focused, and yeah, you can flip to the next. Yeah, thank you. We have a new commissioner. Her name is Danette Smith, and she's very focused on making sure we have a really solid foundation within BHA and also as we're setting up the systems and putting what we need in place to serve all of you. So we want to make sure we have a solid foundation. We want to make sure we have a really robust workforce. We're in lots of communities. You'll see that in a minute. Been going around the state, hearing from folks, and everyone says this is great, but we need to have more clinicians. We need to have more social workers. We need more peer support specialists. the workforce is really critical, and so we're focused on that too. And we also want to make sure that BHA's developing a system that's sustainable, that's focused on access, and to make sure we're meeting very specific needs. One of the charges that came out of the task force was that, one example, we can't treat children like many adults and think the way we've set up the system for adults is going to work for a 5-year-old or an 8-year-old. And we know that. So we're trying to make sure we're being very specific and personalized. We also know that what might work in Denver doesn't work in Teller. What might work in Teller might not work in Grand Junction. What works, so we want to make sure that we're personalizing it for the communities so that you all are getting what you need. Some things aren't unique to communities, and some things are. And we want to make sure that what we're building is responsive to do that. So as we've been going around the state and hearing from folks, some of the things that stand out that Commissioner has been sharing that I've been experiencing with her too is that we want to make sure that when we're out in community, what we've been hearing is that our BHA staff, and James, I think, is some of the validity to this too. That within BHA, the folks that we're bringing in and hire are very aligned with the mission, are all on board to try to make this better and have a hustle. I was an outside person looking in. I don't know if any of you have worked for the state or for big government or any government, but there's always a sense of like, are they gonna move fast enough? Are they gonna make this system work? Do they even care? And I came to BHA and was like, oh my God, every single person is super passionate, really motivated, really ready to do the work. What we've been hearing from community also is that, I hope this is the same for you all, but we've been hearing a lot of support for the work that we're doing. Please keep going, keep going, keep going, do the things you need to do, because a lot of people needed this yesterday and a year ago, and like they're ready for it. And we've been getting a lot of support for the direction that we've been heading. And then also, we've been hearing from folks that don't stop, there's still a lot more work to do. And I get that, and I was the advocate pushing too to say, time moves slow in government, and we can't have it move slow. We gotta keep it moving and do fast. So we've been hearing that from around the state. I was in Durango last week with a commissioner. We had a community engagement, a listening session in Mancos. We've been in Grand Junction. We go to Sterling next week, and Fort Collins and Aurora, those two. But to say we've been really getting around the state and hearing from folks. We're gonna collect all that feedback. It's informing the work, and you'll be able to see all of that feedback and that input in what we're doing with it, not just hearing it and that's it, but to be able to put it into action. We'll have that on our website and available to you all to see what other folks have been sharing and what we're doing. So here are the 5 priorities we were charged in legislation to launch. Get it going. What are you doing? So we have 5 priorities. One was to, you could flip to the next one. Thank you. One is that we've been, all of this launched in July 1, and some of it's on our website, some of it you might be experiencing already or will. So we were charged by July 1 to launch a behavioral health safety net system, and it's to reform and strengthen with public input. And I'll go a little bit more into detail to let you know that we're on track. We were charged with having a behavioral health care coordination system. We were charged with a performance hub, kind of jargony language, but a way that you can log in anytime, go to our website and see how we're doing. How are we performing? And it also is able to share data on how you can access resources around the state. So that's our performance hub. Also to improve on the grievance and complaint process. If someone's complaining about a provider, had a bad experience, how is that being filed? How are we held accountable to hold those providers to do better? That's also now available and improved. And then I'll share more about our children and youth implementation plan, where we've been asked to say, hey, state, you get a lot of money for behavioral health. What are you doing for our kids? And so I'm going to talk a little bit about that too. If you all have burning questions, you're also welcome to ask them. Like, okay, wait, I want to go into more. So feel free to ask questions, but we'll also be able to have Andrea and James join us too. Let me go into just a little bit more detail on each of those and what's happening, and then free to ask some questions. So the safety net system has some new requirements and accountability for providers. We need providers to deliver their services in a really good way, and we have some new requirements. Are there any providers in the room? Any of you? Yeah. All right. I love that. Thank you for your work, helping us to do it. I'm going to talk a little bit more about the new model that we're doing on service delivery. The short word is BASOs, Behavioral Health Administration Service Organizations, or BASOs. So we're implementing a new model of how service delivery happens so that it's more upstream and that it's easier for people to know where do they go when they need the help, and then also to make sure we're ensuring access to services. I'll say that we've been working a lot with HCPF that does the Medicaid side, and we want to make sure that the system they're putting in place to serve people who are eligible for Medicaid is similar to the system we're doing for all people. We're also working a lot with the Division of Insurance. So just no matter how you get paid, how the service gets paid, we want to make sure you're getting what you need. And there's a lot of work to be done to improve the way those three entities work together, but we're doing that. The next one I wanted to highlight, so the BASOs, have you heard of the BASOs? Any that maybe our providers have? James has, okay, a couple of you have. So we're changing the way we do the work. So we just had a notice of intent. We did a big RFP. We had really good people with lived experience from all over the state be part of the decision making to select them. We put out the notice of intent. That's the state process to make sure everything's legal and done right. So we have a notice of intent. We divided the state into 4 regions, and we have a BASO selected for each region so that you all know, here's the service provider, the main one. If I know nothing else, you'll know who that is, and you'll call them when you need something. And they will have a network of subcontractors, and we're going to build out the system to make sure that there's lots of folks, you have resources in your community accessible, and it all starts with this BASO, the service organization that's the primary provider for you all in the community. So we've been legislated to make sure we're on track to implement this model, and this shows you where we're at in it. So this fall we'll have the formal selection of those vendors, and then by next summer, July 1, they're up and running. So we did the notice of intent, we're gonna have them under contract in January, February, and then they will be setting up their subcontracts, and then they go live on July 1. It's a big effort, and we're hoping, the aim is to make it simpler for people to know how they access their services. I'll show you the map and where you all are. So all of this on our website too, and we're happy to share any of the details you see today. But on the map, the 4 regions are color-coded. You all are in red, and so Signal Behavioral Health Network they've been noticed, the notice has gone out, we'll get it under contract, but Signal will be the primary, the BASO for your county, for Teller, in that larger region in red, and then they'll continue to set up subcontracts to provide services. We're also looking to build that out, so it might be the same providers that have been, that's great, but we also need to build out that network to make it more integrated, to make it more culturally responsive, to make sure we have what people are needing. We're not repeating the same old, because some of it's worked and some of it's not, but it hasn't been integrated and it hasn't been easy to access, and we're trying to improve on that. So this is the way the regions are set up. Rocky Mountain Health Plans has the blue, and then Signal has the other 3, and they'll set up networks in each of them. Does that make sense? Okay. One of the other accountability measures that we wanted to implement was that we were charged with a care coordination system. How do people get the care they need? How do they navigate the system? And so I'll just touch lightly on it and then lean on Andrea to go into more details if you're needing more details on that. We can go to the next slide. Except it might be frozen, so we're just going to look at our state. So we'll do that. But for the care coordination system, it's really about helping people navigate both when they're in hospital settings and they're under involuntary commitments, and they're needing to go to a better level of care. They've gotten what they need in the hospitals. They need to step down, be in another more appropriate setting for where they're at. And we help BHA directly deliver services to help hospitals, help those people to find the right placement. The other way we do it is for those involved in the criminal justice system. When they're needing care coordination, we help to do that too. So that's what this care coordination system is all about, and the ways that we're trying to improve for people in both of those settings. The other one is the Performance Hub that I mentioned. That's already been launched. It's a data bank. And so if you're wanting to find data on how providers are performing, if you're wanting data on where do you go for something, you can go to BHA's website, to our Performance Hub, and be able to see that information. And we can go into more information on that if you're interested in that. So all of this trying to be very transparent, trying to hold us accountable to build out the systems, but ultimately it's all about providing you better care in a more accessible, affordable way that centers you in it. One other piece I mentioned was the grievance process. We have a role in BHA to hold people accountable to do good work, to hold providers accountable, to hold people who are licensed to do good work and serve people in a good way. And we take that responsibility very seriously. And the public was wanting more transparency, wanting a better system to know if someone's filed a grievance on a particular provider, we should be able to know that and know that BHA has held them accountable and they're improving. And that's what we've been working on to make sure that our grievance and complaint process is, one, easy for you all to file those grievances and complaints, and also easier for people to know that something's been done with that. And so that's what we've been working on, and also available through our website if you want to take a look at that. The other piece I wanted to share then is the Children and Youth Plan. So we heard we need to make the systems better for kids, so the state created a plan to be able to, for you all to know, what are we doing to help kids and young adults? How are we going about that as a state? So the state has millions of dollars that go to multiple departments, and our job at BHA, coordinate all of that, find out where all that money's going and how it's being implemented for our kids. So you can go to our website. The Children and Youth Plan is there. I'll say though, it's written in a way that's kind of hard to read. So it's very academic-y. So just know that going in, and I'm working to change that so it's easier to understand and sift through. But I'll share that there are 14 state departments, including the Lieutenant Governor's office, that meet every month as a steering committee that are in that plan, and we've mapped over 109 action items that we're actively working on that will help improve the lives of our kids through the services that they're getting. And so when you go into that plan, I'll have a tool soon for you to see. For those of you, any clinicians in the room, therapists, social workers, any of that, all right, our people. There's what we call the care continuum, a system of care in which you go from screening young people, even adults. You get screened to see what you're needing. You might need a more in-depth assessment. It starts to figure out what are you needing for your care, and begins on a continuum of light touch to really intensive wraparound services to recovery and transition. So on that care continuum, these 109 action items are there. What can we do at each of those phases to make it better? We also took a look at what's BHA doing within our administration. Things like I Matter, some of the youth direct services, crisis care. What are we doing? And we've aligned that to that system of care so that the public should be able to see through our direct service delivery, through that youth plan in all 14 departments, what are we all doing to coordinate, collaborate, to be better for our kids. That's what that youth plan is all about, and we're delivering on that. Things like the BOSSOs and how they serve kids. We passed legislation with some sister agencies, 1038, that was all about kids with the highest acuity needs, dual diagnoses, disability. How do we serve those kids? And so we've been making strides to help make all of that better. So I flag that for you to say, please look at that. I'll make it better, easier to read, and all of those things. But just know that it's there, and we want the public to be informing the work that we're doing. We're putting out a progress report by year end, and so you'll be able to see how we're doing on that. Okay. That's right. All right, I love it. So I'm in the home stretch, folks, because this is where you can then, we want to be better at you all connecting with us. So we've changed the way we do our engagement. We want to be a North Star for how the state engages with community. And we're seeing that in how we're out in community now and with the new commissioner and doing these listening sessions and being accountable to saying, how is all that input being put into action? One of the other things we did was that we hired staff who actually live in communities around the state. I know, I'm seeing some like, wait, the state did that? I know, we did. So we hired engagement specialists from around the state. It does not match the BOSO mapping. It matches how people live and how people want to be hired for jobs, and so we wanted to be responsive. So we have, again, all of this is on our website, but we have 4 engagement specialists. We spread them out around the state so that we can have a bridge in communities. And I know, like for you all, the engagement specialist lives in El Paso County, but it's close between El Paso County and Teller County. Marius is their name. So we have these engagement specialists around the state who can then be that bridge. So you all can reach out to me, and Andrea, you've met us today. We're gonna hang out over break. But in the day-to-day, you're welcome to reach out to your engagement specialists, and our engagement specialists are reaching out to communities. If there are things happening in Teller County, Marius can attend and be there and support. He can take your questions and they can bring them back to us. Be in community meetings, meet with folks, and help inform the work that way too. So see them as bridges from your community to us if you need that, and just know you can also just reach out to us directly. But we wanted to make sure we had folks in community and also helping elevate the voice of community in the work. So Calandra's on Eastern Plains, lives in Sterling, 3-generation ranching family. Brittany is in the Denver metro area and works from there. Marius Nilsson lives in Colorado Springs but serves you all. And then Rachel Simpson lives in Grand Junction, serves the Western Slope, is that bridge for there, and is also connected to the tribal community, and so helps with those relationships also. And we'll make sure if, we can get you their contact information. So I just share with you embedded in community, help elevate your voice in the work, and also help you to elevate your own voice and your community's voices in the work too. So they don't have to speak for you, but help you to be that bridge to be able to engage in the work. One other, a couple of ways for you all to be involved, and I'm going to bring Andrea up in a minute for some of this, or I'll just clip over it and we can ask questions. So we have one more community conversation. Won't be the last, but just for now. That's in Sterling. It's on the 24th. And on our website, we always put dates, upcoming dates, so that people know what's coming, can plan ahead and engage in our work. If you all know anyone from Sterling, connect to some of your providers. If you have sister orgs there, we would love for folks to participate. We've had really good turnout. Even in Mancos, over 17 people showed up and spent their evening with us and giving voice. And in Pueblo, there were over 60 people that showed up. So just good turnouts, really thoughtful input. The other place in which you can be involved, this is where it gets really wonky, but some of you like all this nerdy stuff. We have rulemaking. So we have to do things, but you have to tell people how to do them. How do providers know how to follow the rules to make sure they're fulfilling their license or their delivery? How does BHA know? How does our system work? We need rules to do all that. So the rulemaking process is underway. And there's 3 different kinds of rules, but we have public forums in which you all inform the rules. It isn't just us alone in our room writing up rules. It's informed by community. So we'll share those dates too that we have on our slides. And there's lots of feedback that we need to do that. And so just know that that's coming up. We also have lots of advisory councils, things like that for anyone interested. in serving on any of that. We stipend and support people who want to be involved, so just let us know how you do it. Well, thanks for showing up on a Saturday morning. I know it's kind of high level or direction, but it's part of us making sure you all know what we're doing, and if we need to do some other things, we'll do them. I was on a call yesterday with disability advocates and from rural communities saying what they need in the kind of residential placements. Why can't this or that be easier? So just know that we're open to that, and we want to make things work for you, and that's why we're sharing our morning with you too. So I'm going to pause here. I'd love to just open it up for questions or comments or anything that's top of mind for you all, and I'll just sit here with Andrea and James and hear what you might have to say. So thank you. Yes. So
There we
she
go.
asked
Got it now.
about.
Just make sure you use the microphone so.
Yep. Thank you. Can you hear us okay? Is this mic? Okay. Thanks for that question. And I'll have Andrea chime in if I missed something. So in general, we're our own administration. So we're an administration. We're our own. Think of it like a state department, like Department of Transportation, Department of Early Childhood, with a little bit of a caveat. So we're our own administration department, but we're housed under the Department of Human Services. And that has to do with statute and how many people can serve on a cabinet and logistically kinds of stuff like that. But we're housed under them, but we're our own entity. And then we're funded both by state dollars, by federal dollars, like SAMHSA. We also have had money from ARPA, the stimulus money that came from the pandemic, that the federal government gave to all states to be able to do good work. So we've had millions of dollars in ARPA funding, as it's called, to be able to do good work out in communities around the state. And then there are some grants or things that kind of come in as any state department. Does that help? Yeah, thanks. Yes, Corey. Yep, thank you for the question. She asked about what happens to kids who aren't on Medicaid and don't have insurance. So that's where the Behavioral Health Administration comes in. So that's that safety net sort of perspective. So you have kids, families, people who are qualified eligible under Medicaid. You have folks that have private insurance. And then you have folks that don't have either of those. And that's where we come in. That's who we serve. There's also the underinsured. You might have insurance, but they're not going to cover some of the things that you really need. And so that's the system that we're looking at making better for everybody on how that works. It takes a lot to work with, not just division of insurance. They're the ones who oversee insurance providers, but they don't oversee all of them. So there's a lot of work on how insurance plays into this, a lot of work with Medicaid, and we do have, we've been working a lot with HCPF, healthcare policy and finance on that piece of it. One note, this gets into the minutia, but Medicaid uses what they call RAIs, and ours are BASOs. So what we did was take the map of Colorado and go, where are you, HICPUF, putting your raise? And we're going to use the same exact regions, and we're going to have our bossos be there. And we're going to have them talk to each other and staff connections to make sure that if someone drops off the eligibility for Medicaid, how do we pick them back up until they're able to have the insurance coverage? And so we're trying to coordinate all that to make sure it works well.
I would just add, we're not, so BHA, unlike HICPUF, that's my favorite state acronym, took me a couple weeks to learn that one. That's Healthcare Policy and Finance. That's just Medicaid for the state, basically. We're not a payer of services. We don't insure uninsured or underinsured. You don't like carry a card that says, I'm insured by the BHA and can get into their programs that way, which actually makes us a lot more nimble in what we're able to do, and like we can broaden the safety net of those services for populations based off of how specific populations are disadvantaged around the state, which our bossos will do regionally, right? To say, okay, BHA's service population in this region is underinsured is 200% of federal poverty line, where in the urban corridor it's 300%, right? It allows us to tailor those sort of who we're serving and why based off of the regional differences around the state that we see in insured, underinsured, and uninsured populations, because obviously all three of those words look very different depending on where you're sitting in the state.
Can I show how that's practically applied
Please.
and how it impacts this community specifically? So again, I'm the director of community parent medicine for Ute Pass Regional Health Service District. If you look in the back, I've got two of my providers back there, and they are actually community paramedics that respond in small SUVs to behavioral crisis and substance use disorder crisis. So when somebody calls 911 or somebody calls 988 or someone calls Colorado Crisis Services or law enforcement shows up on scene and sees that there's someone in behavioral crisis, or an ambulance shows up on scene, or the school district recognizes that somebody at the school is struggling, or one of the local churches recognizes that someone is struggling, they can reach out 24 hours a day, 365 days a year, and ask for what we call a MAP response, or Mental Health Assessment Program response. That program is 100% funded by Colorado Crisis Services through this model. So, and if this funding didn't exist, that program wouldn't exist. Now, I say 100%. The truth is it doesn't cover 100% of the funding. We're able to bring in other sources of funding to help offset that and cover 100% of the cost. But it wouldn't be feasible without that funding. So the money comes from the BHA into our previous of the Bahaso to a group called CareLoan, and then we contract with CareLoan to provide those services. And we're held accountable for meeting certain measures and for doing certain things to make sure that you as a community are receiving the top quality care. And so we're able to have these providers go out. We can medically screen to make sure that you don't need to go to a hospital, right? Now, what happened historically is anytime somebody was in behavioral crisis, a bunch of cops would show up, a bunch of fire engines would show up, a paramedic in an ambulance, or two paramedics in an ambulance would show up. We'd all burst into your house, we'd crowd around you, we'd stand around you, understanding that we're the experts in your crisis and we know what's best for you. Right? And then we'd grab you, more often than not, honestly, grab you, drag you out of your home, and take you to one of the most inherently unstable environments I can think of, an emergency room. And you could sit there for 2 to 3 to 4 days. Like this is the insane system, and this is how it looks. And honestly, across the state, unfortunately, there's still communities where that's what it still looks like. But you guys don't have that because we have that relationship with the BHA. So we medically screen, make sure that you're okay. We can do lab work, urinalysis, everything right on scene. And we work with board certified emergency physicians and nurse practitioners to make sure that you're medically stable, and then we de-escalate your crisis, and then work with telebehavioral health professionals. And I'm happy to say we just hired our very own psychiatric nurse practitioner to join our team. And so that gives us the ability to help patients who don't have access to medication management, patients that don't have access to ongoing, counseling until we can get them tied in with a community partner for counseling. We work with community partnerships so that if a patient needs wraparound services, we can get them referred to those services, right? The Teller County Mental Health Alliance has a ton of partners that we can get people connected with so they can get the services they need, because the truth is that the fix to behavioral crisis is connectivity and connection. And if loneliness and isolation is the leading cause, one of the leading causes of disease in the United States today, it's one of the leading causes for death from heart disease. It has increased rates of diabetes, hypertension, high cholesterol, suicidality, depression, alcoholism, all of these things, substance use disorder, right? These are all connected to, and we have people living on 200-acre parcels for, sometimes, right? And so I didn't mean to tell you, I just want you guys to understand that's the power of this partnership. The vision that they are building is alive in this community, and I think you guys should be very proud of what you're doing as a community, because you are a shining example for the rest of the state.
Thanks. You talked about the grievance process. Do you have a relationship with the Department of Regulatory Agencies? And if so, how does that work?
I'll take that one. Full disclosure, I'm an attorney. I'm not BHA's attorney. I don't litigate on purpose. I don't like doing it. So they let me write policy instead, which I'm very thankful for. But in terms of, okay, I'm trying to think of the best way to explain this.
Yes, we work with them. So
Yes, okay.
DORA regulates certain pieces of the system.
Okay, so DORA, what they're responsible for is occupational licensing, right? Which means that they provide the license to the actual service provider, the behavioral health nurse, the aide, the doctor, right? So, and all the people actually administering the services, carrying that license in their professional discretion. That's DORA. Clearly, that would have an interplay with what we do, which is regulating the service delivery itself, how that service is delivered, not by whom or how that specific person has to deliver that service, but say outpatient services, crisis services must be available in this area and delivered in this way. You as a safety net provider, your facility must deliver the service in this way, make these grievances available in this way. If you have a grievance against a specific provider for something they have done, that would go through DORA. If you have a grievance about a outpatient behavioral health provider's policy, that would come to us. The great thing about what we've managed to do with the updates to our grievance system is we now have a window into all those complaints from DORA, all the complaints from HCPF, right? All the different complaints across state agencies, regardless of how they came in, we can now information share and have a lens into that. So we would know if there's a problematic provider, per se, within our networks administered by our bosses. The range of penalties for that, as it were, after investigation, again, DORA would take action on an occupational license, we'd take action on a facility license, but in no universe should we not be talking to each other as state agencies and knowing what's going around, going on within behavioral health spaces. That's what we mean by networked government or braided government, or just the left hand knowing what the right hand's doing. But that's the distinction between DORA and what we do, is we're facilities, not people. Does that make sense?
One other way I'll highlight is through the workforce funding that we received for ARPA. We wanted to make sure, one of the ways we wanted to invest money was to build the behavioral health talent pipeline. We need more social workers, we need more peer supports, we need behavioral health qualified assistants. And so we worked with Dora to say, if we're gonna invest in something, what's the licensing needed? How do we help, for example, scholarship people to be able to afford getting the license, even if they had the credentials and all of that? And then we worked with other partners, community college system and Medicaid. Could they, if they get the license, could you be billed as a, can the provider bill for a qualified behavioral health assistant? And then how do we make the cert stack so ultimately Dora would have a license they could then they can then go after. So just another kind of nuanced way that we've partnered. But great questions, thank you.
We have time for one more question, 5
Yeah,
minutes.
I think, and the,
I'm coming.
I think you have one in the, yeah, it's behind yours, you're waiting, thank you. And we'll be here on break also if you want.
Okay. You talk about the children. We have children, I work with a delicate population of kids in high school. Under the current climates, I don't want to get political, mental health has been taken out of our schools. We have children falling through the cracks. We don't know about your program in the community per se. How do we get your information out, more publicity, if you will, to the parents so that the parents have a choice of where they can take their kids?
Yeah, thank you for raising that. We're very cognizant of using school-based settings or structures to deliver information and services to kids, to youth, families. We have early childhood settings within schools, pre-Ks within schools, and so it runs the gamut. And often we use the school setting to be the mechanism by which we do outreach. And that works in many cases, and in others it doesn't, might not be as what you're describing. And so our communications team does a great job, and we'll be doing more on just public outreach. So you don't have to rely on the school being the one to send the info out to whatever's needed, but to be able to do public outreach. So 988 is an example of that. iMatter, we don't just use schools, use community-based groups. For Lift the Label and for ways to get substance use disorder supports, have recovery cards that communities give out in their own way to help people connect and feel like they're valued. And so we're cognizant that we haven't solved for all of it, but I think the public outreach part where we don't just have to use the school setting is one way in which that can happen. Also using our providers that are in communities, just think of all the churches and other ways in which people connect and get resources, barbershops, even in some areas, and salons, more culturally appropriate ways in which some people, whether or not the school offers it, don't trust the school to do it and don't trust the state or trust it. So we're trying to find who are those trusted messengers in communities to be able to share information. And so that's the approach that we've been taking and are on path to do.
Can I give some more to that too? I'd like to give the local flair on that. And so what we're doing, because you're right, that is a problem. Access to the kiddos is I think it's, if we're honest, it's been a concern for most of the community over the last couple of years, right? And so what we're doing to get the message out there is, first of all, you're going to start seeing all of our vehicles now have messaging boards on them. And so when they're going through the community, you're going to see Colorado crisis messages actually communicated on our vehicles, so that when people, when they see those vehicles go by or when they see those vehicles parked in an area, they can actually get that message, and it reminds them of how they can access services. We're at the farmers market every single week during the summer, getting that message out, and then community events like this are so important to us. We have Colorado crisis material that we hand out at events. I just received 2 new cases of Colorado crisis material that we're going to be handing out. I also have some really cool swag that they gave us that is absolutely phenomenal that we try to hand out to kiddos and to families, and because that's word of mouth, maybe you put a card in your phone today, or in your wallet today. I say in the phone because let's be honest, the kiddos today, right, they're putting it in their phone. So but you put a card in today, they may not need it for 6, 8, 10, 12 months, but it's there. And that's our goal, is to plant that seed today that grows into the tree that they need in the future.
We're going to take a 15-minute break. We'll reconvene at 10:15. So during the break, again, the bathrooms are at the far end of the fellowship center, off to the right. And encourage you to check out the tables of the organizations that are providing materials. We have some coffee. There's still some of the breakfast stuff available. So thanks very much. We'll see you.
Thank you, Andrea and Kelly. Thank you. And they're going to stick around if you have additional questions that weren't able to get answered during the Thanks, Mike. Thank you.
All right, we're going to get started on the first panel discussion about substance use disorder and recovery. So I'm kind of just calling to people that are still out navigating the booths before we get started. I am going to try to be a stickler for time today, so hold me accountable, okay? All right. My name is Ashley, and I'm the Suicide Prevention Project Coordinator for Teller County and with the Teller County Mental Health Alliance. And have really gotten to know some cool people the last couple of years, and just honored to have our panelists that are here to just talk about their own experiences, connect with us in the community. The goal really was to, again, connect with Teller County. And it was awesome to have state folks here to talk about state stuff, and it's important too to hear the stories of people that live here in Teller County. At the end of today's panels, there's going to be a Q&A option. I don't know how comfortable I am running in heels to you with a microphone. I'm happy to do it, but I will also be putting up a number for you to text your questions anonymously to as well. And so just know, after I do introductions, that slide is going to come up. So throughout our discussion here today, the last 15 minutes, I will be asking those questions that you submit to me. So Teller County's community health assessment that was done by Teller County Public Health identified mental health and substance use as the top two issues here in our community. Substance use disorder is a disease like diabetes and cancer. When a person is sick with serious illness, family, friends, the community, support groups all come together to care for them. When it comes to those struggling with addiction, people often back away instead of leaning in to support them. Educating others, being informed, leading by example, and staying open to receiving and hearing what people in recovery tell us are ways that community members can be a part of the solution. Everyone can learn to understand the signs and symptoms of distress and how to refer people to support those without re-traumatizing those that are struggling. When the community holds regular conversations and acknowledges those suffering from addiction, it helps them to change their lifestyle and to make a plan to move forward with support. The process of recovery is highly personal, and so I just wanted to put that out there. There are a lot of pathways to recovery. It may include clinical treatment, medication, faith-based approaches, peer support, family support, self-care. There's so many different things, which we're going to hear about today, some of the journeys. We're working to shed light on substance use disorder-related stigma as a barrier to recovery in our community and address myths about substance use disorder that may prevent someone from reaching out for help. The panelists that are here to share their stories today are, first we have Nate Wilson. Nate is a husband and father, author of 2 books, and business owner of New Visions Recovery Solutions here in Woodland Park. Nate has been clean from heroin and meth for 14 years and free from alcohol for 8, so let's give him a hand. Nate is an advocate for using fitness and physical activity to improve mental health and help with addiction issues. So welcome, Nate. Thank you. Next, we have Eric Olson, who is the Director of Strategy, Colorado Strategy for Face It Together. Can you raise your hand, Eric, so people know who you are? An organization that provides non-judgmental peer coaching for those impacted by addiction, including loved ones. Eric has struggled with his own addiction for 20 years and has been in recovery for 4 years, so give Eric a hand. Woo. And he's lived in Teller County for 3, so I guess technically you're considered a resident. 3 is the minimum. Next, we have Frank Montesano, who is a national certified peer recovery support specialist and has been for 3 years. Raise your hand, please. Thank you. He is in long-term recovery and has family members that have also struggled with addiction. He is currently at Serenity Recovery Connection as the Outreach Program Manager and runs the homeless outreach team with the Colorado Springs Police Department. Frank has successfully expanded services to rural areas like ours and also Fremont County and eastern El Paso County. And how long have you been in recovery, Frank? 5.5 years. So I have some questions, and they're not in any particular order, but I did want to ask all of you, what has your experience been struggling with addiction? And you can share your story generally, specifically, however you want that to look, but I'm going to give you kind of a hand signal if you're talking too much. You don't have to press a button on your microphone. So we have a wonderful person back there who is helping to regulate all of the sound. So please don't push the button because it will never come back on again. Don't push the button. So we have that, yeah, we're good. If you want, totally fine. I was just making sure your mic works. So what has my experience been with It's not on. Here, I'm gonna give you mine. Because I know it works. Apologize.
So because I was messing with the microphone, I didn't hear all the question. Could you? Yeah, good question. When I was growing up, I was going through addiction from about the ages of 14 to 21. I'm 36 now. So that was back in 2004. Up until about 2008, I was getting into hard stuff. In Woodland Park back then, I think the perception of the community and addiction was a little different than it is now. And I think there was even more of a stigma back then, especially. It was treated more as a criminal issue and a moral issue, as opposed to, hey, what has this kid been through? Why is he making the decisions that he is making? And how can we help get him resources? So back then, especially within my home, my family took me to church every Sunday. Both parents were there, but they were very religiously oppressive. And so I would go as far as to say there's a term I heard recently called spiritual abuse. And there was a little bit of that in my home. And, I didn't have bad parents. I think they did the best they could, but they tried to use that to try to will me and control me. And I ended up rebelling. And I also had some childhood issues that were undealt with. There was some trauma there. And so for me, there was just a lot of shame growing up and being the bad kid. And I started out in the early parts of my childhood as playing a lot of sports, being involved in school. I was, the popular kid, this and that and the other. And then when I was struggling and I chose to, use drugs for the first time, and that turned into addiction, the perception and my reputation, the perception of who I was and my reputation within the church and the community changed, and it was very hard to recover from that. Now, I have recovered from that, and I've been very loud about my recovery and what people can do once they choose to heal from all those things. But that was very hard growing up for me, to answer your question, just because of the stigma around addiction. I do think it has improved, though, just from my perception.
Is this on? Okay, it's working. So you do hit the button. Anyways, so can you kind of repeat it real quick?
So what has your experience been like navigating addiction or struggling with addiction?
Okay. Well, for me, much like many people, much like Nate, growing up in a high school, kind of experimenting, kind of, led into like more and more use, and it just was kind of the way of life. That's what we did as teenagers. I didn't grow up in Colorado. I grew up in the northern suburbs of Minneapolis, right on the cusp of like city life and farm life, so not a whole lot to do. So that was definitely, what we did for fun, much like, many parts in America, Woodland Park included. So, but that kind of, going into my 20s, just kind of my use just kept getting, worse and worse. I'd have to drink more and more due to tolerance. And then kind of, just in that, like I said, 20 years that's lasted. But, the biggest thing that it really affected was, not only my relationship with my wife, but my relationship with my kids. I have 3 kids. And then, 20 years into it, I just said enough was enough, and I just couldn't do it anymore. So that was back in 2020, amidst the pandemic and everything. But then that's also where I found Teller County. So Teller County's been part of my recovery because, it's a beautiful place up here. And now I'm able to use that story and kind of help people that are in the same struggles, up here. And I love it. So it's kind of my journey.
Thanks for sharing.
Is it working now?
It is.
All right. I think we figured this out now. I have quite a bit of time navigating my addiction, so I'll try and just hit some main points to it, I suppose. Most of my family's actually struggled with addiction, including both my parents and my older brother. So I think I saw reality with that kind of at a young age. My dad drank a lot. I saw a lot of abuse. And when they got divorced when I was 7, my mom had full custody and she changed her life around. And I think that was for the better, but I think that kind of started a lot of it, I was like, my dad was in his addiction his whole life. My brother was in his addiction. I looked up to him a lot. I kind of walked in his footsteps a lot. So I think that led to me starting at a very young age, and I was introduced to opiates at a very young age, so I was addicted to opiates very early on in my life and navigated that all the way into my early 30s. And in doing that, I tried to go to treatment numerous times. I wanted help all the time. I didn't really know how to ask for help. I think, like we were talking about before, Nate was, with the stigma around addiction. None of us really want to talk to people about our addiction problems and to ask for help. So a lot of times that keeps us in our addiction for longer than we want to be. But after numerous times going through treatment, it went this last time, and I followed the whole continuum of care like I never had before. I actually listened to people and what they told me I should do, and I actually wanted the help that time. I was highly encouraged by the judicial system, and I think that's what I needed at that time, and glad to say I'm completely off paper now, and I went to treatment for 8 months to make that necessary at that time, and ever since then I've sustained recovery. I've built a career using my lived experience now, and even though I had those felonies, I'm still able to do what I love, and I'm passionate about it, and have built a career around it, and that's a little bit of the navigation there.
Thank you for sharing your stories. Just to add some context to follow-up questions that I have. Eric, what would you say is the most important piece to healing or overcoming addiction?
Well, first and foremost, you have to accept it. You have to, realize that you do have a problem, but that doesn't have to be a barrier to, keep using though, So once I realized, hey, and I finally was truthful with myself that I do have an issue, for me, I went through a 90-day intensive outpatient program, and that's how I finally, maintained sobriety. So I got that 90 days of sobriety, utilizing the tools that they teach you in there. But then you're left to you're left to your own thing. You can do whatever you want once you're done with that program, right? So finding that support. So really admitting to yourself that you have an issue, and then realizing that you can reach out for support. Much like we've already heard, stigma, there's a huge stigma with asking for help, especially from a guy's perspective. We're supposed to be able to figure it out on our own. We don't need to ask for help. But, that's I had a brother who, struggled with alcohol as well, multiple DUIs. So I was able to talk with him because he's been there, done that. And, that kind of really helped me get to where I needed to go to. And then eventually finding Face It Together, much like, Frank, being able to find a career in recovery has helped my own recovery as well. So it's kind of amazing. I never thought I'd be able to do anything. I never thought I'd be on a stage like this talking about recovery or addiction. So this is, just an honor to be here. But yeah, just, accepting it and then seeking that help. That's what's helped for me.
Thank you. Frank, how has your experience shaped views on effective approaches to recovery? So you said you've been through the gamut in terms of services that you access throughout your recovery. How has your journey shaped what you view as most effective?
So I think along my journey, I realized that there's not just one size fits all to recovery. There's multiple pathways to recovery, right? And you got to find that pathway that works best for you. And that's kind of even what I do as a career now, is help people find that pathway. And for me, through my journey, I didn't really, I guess maybe I wasn't listening to that the whole time. But I tried, all the normal pathways, like go to detox, you go to treatment, inpatient treatment after that, and then I would think I was good. And then I'd go back to the same lifestyle afterwards and start it all over again for another 2 years. But I think, what really worked for me this last time that I went to treatment is that I did it for myself. I went through all the continuums of care. Like, I started with the peer coach and found the insurance that I needed to get into treatment that I didn't have before that. They got me into an inpatient after that, and it was all medically assisted, which I absolutely needed at the time. And I think without that, I probably would not have sustained that recovery that I did. And I was able to get some sober living paid for a while, and that led me to focus on myself instead of worrying about getting a job right away. And I did an intensive outpatient treatment during that, and just slowly worked myself up, built up my confidence, and used all the resources that were given to me. And along that way, I found things that I had been passionate about before. I started working on my foundational items, home, health, purpose, and community. I think some of my pathways that I found are probably, similar to one of Nate's: exercise and nutrition. That's really helped me sustain my recovery a lot. And then, like Eric said too, working this job, helping others, helps me in my recovery. Supporting other people and helping them find their pathway taught me so much about my own pathway. Yeah, that answer it?
Yes. Eric and Nate, do you want to expand on that at all, or do you have connections to that?
I would just echo what Frankie said, that I think that's a very subjective thing, and it's going to be different for each person. I think what's cool nowadays about what I'm seeing in the recovery community is it's not just, hey, you have to go to detox and then go to AA and rehab and go that route. While those things are very good, and I would suggest going to detox and rehab and everything, AA might not be for everyone. We have different support groups. We have smart recovery. We have group therapy. You can go to individual therapy. For me, going to the gym has definitely been the best thing for me. It's I get a rush out of it. I feel better afterwards. I feel more like myself after I pick up a bunch of heavy things and put them back down. And it's as simple as that. So, yeah.
Yeah, there is no right or wrong way, to find your recovery. There's multiple pathways, like he said, AA, is not for everyone. Some people love it. Like even myself as a peer coach, peer coaching is not for everyone either. Sometimes people need some additional support. Maybe they need to find like an intensive outpatient or even an inpatient, depending on where they're at. But as a peer coach, you know, we're here to help you try to figure out what's best for you. You know, we don't define your success. Success is whatever you define it as. And so there's many people, you know, sometimes people, you know, just need to, you know, have like a harm reduction, not use as much of whatever substance they're using. So, I mean, there is no right or wrong way. It's just really finding what works for you. And if you try something and it doesn't work, try something else. There's tons of different ways to find recovery. I wish I could, you know, say I was in the gym like these guys, but I should probably go with you guys. But anyways, but yeah, no, just really there is so many options out there. So just don't feel like if you know someone that's struggling, or if you're struggling yourself, you know, you don't have to go down whatever someone says you must do this or you must do that. You can find your own way. So.
A question that is coming up for me right now is how, if we're supporting somebody who is struggling with addiction, how do we support them? So if it's somebody that is close to us, because there's a right way to do it and there's a wrong way to do it. Can you tell us what to do?
Okay. Well,
We're all like,
I turned my button on first.
I'll tell you.
No, I mean, going, you know, back in the 1900s, it wasn't, you know, that's what my kids say, you're from the 1900s. But anyways, you know, tough love was a huge thing for that person struggling. Well, you don't have to be that way. You can use compassion and you can be there for them. And, you know, a lot of times as a loved one, you can just build, you know, work on communication's key. Like if you don't have good communication, you're not going to get anywhere. So communication, setting up some, you know, boundaries. But, you know, we found, you know, and we have a whole loved one program at Face It Together where compassion works. And you don't need to be, you know, you don't have to do that tough love thing, which, you know, it does work for some people. I ain't going to lie and say that it's never worked, but, you know, but then you're just isolating that person, making them feel down and bad about themselves. Like there's a way to use love and get the message across at the same time. So.
I agree. No, it's very difficult trying to support somebody that you have like emotional ties to, especially in recovery. Because, I mean, I witnessed my mom try and do it with me for 15 years. And that'll just, you know, you're putting a lot of harm on their life, you know. So there's a time when they need to realize what's best for them and work on some of their own self-care. And that same program Eric was talking about for the loved ones, we have a craft group at Serenity Recovery Connection too, and that teaches people how to be kind and supportive to their loved one that's in addiction, and teaches positive communication skills and a reward system for non-drug using behavior and how to not reward drug using behavior. The big word that we don't like to use, enabling. So they just facet it in a different way like that, and it's recommend not trying to do it yourself, because I've tried to support my own brother in it too, and it's just really difficult. I'm not trying to give any advice or anything, but I think it's best that, you know, somebody else kind of supports them through that, and you can be there offering the kindness and compassion like Eric said.
I think asking a lot of open-ended questions to someone who's struggling, and asking questions to try to understand their perspective. And it's tough to do because people in addiction, their thinking is skewed. They're under the influence and they have trauma and they're in fight or flight mode all the time. Their brain is in constant fight or flight mode, so a lot of what they're saying might not make perfect sense to you, but to try to understand it and understand why they're presenting with some of these behaviors, I think is great. I think educating yourself in boundaries too, so that you can show love and compassion, but know when you're enabling or getting taken advantage of, or all those things. But listening to understand, I think, is very helpful, because that helps establish that connection. And if you're ever going to offer any advice or anything like that, it's not going to work unless the person you're talking with trusts you and trusts that you have their best interest at hand. And that's not going to happen unless they feel like you understand them.
Thank Nate, I wanted to come back to you. You grew up in Teller County, and you've seen stigma play out in the space. What does it look like today? How is it viewed today, do you think, in Teller County? How's that shifted?
Yeah, I think there has been improvements, and like listening to James, the paramedic up here, talk about how there's resources that where it's not just a bunch of different cops and paramedics and a bunch of sirens and lights coming into your home and dragging you out of there. I think we are improving how we deal with substance use and behavioral health, but that's a process, and I think in our country and our communities for years and years, addiction and behavioral health has been misunderstood, and so we're still trying to eradicate some of that and get a better understanding of it, and Teller County's no exception to that. But there has been some positives. So I went to an opioid epidemic symposium a few years ago. This was at Impact Church, and some of the sheriffs were there, and they were talking about, hey, if someone's struggling with substance use, we don't just automatically slap the cuffs on them like we used to. We want to offer them resources. We want to give them other avenues that they can get clean besides going to the slammer. I was like, man, where were you guys 15 years ago? But it has improved. However, there's still, it's tough to say what the majority thinks. I wouldn't be able to tell you what the majority of people think in Teller County, but at Panther, I work with the alternative school here, and at Panther Academy a few years ago, that's what it's called, Panther Academy. Just to give you a little background, Panther Academy is an alternative school for kids who would normally get expelled or kicked out of school. This is an alternative school for them to go to so they can still graduate or get their GED and get education. I asked the kids a similar question years ago, and some of the kids replied that they feel like the town is kind of cut down the middle, and you have the good families and the good kids, and then you have the bad kids and the bad families. Now, whether or not that's true, I'm sure there's truth to it, but that's how they felt. That was their perception of things, so they're going to act accordingly. And I felt that way growing up as well. And I know that, I grew up in this good home. I had good parents, but as soon as I started making bad decisions, I crossed over, and I didn't feel like there was any coming back from that. Now, a lot of that was just my perception, and I realized that some adults, sometimes it was just accountability, and it felt like adults were out to get me, so some of that was on me. But there's some truth to that, too. And like I was saying, it's all about perception. So even if it's not truth, that's still their perception. That's what they understand. So there has to be a way to try to communicate to them, you're not bad kids. You're not unsavable. We're not out to get you. We just want some accountability. Here's some resources. Here's where we can get help. How can we support you?
This is for all three of you. Don't all talk at once. What are misconceptions about substance use that we can squash right now?
It's okay to ask for help.
So you're saying it is okay to ask for help is a myth?
A lot of people don't think it's okay to ask for help. Sorry.
Okay. So it is a myth that it is not okay to ask for help. I just want to make sure that that's clear. Can you expand on that, Eric? Thank you.
Well, I mean, just like so many, and especially working in Teller County now, and getting to, hear some of these stories. So many people, they just, especially men. I mainly work with men. We're not supposed to ask for help. We're not supposed to share our feelings. We're not supposed to, it's just help is, we need to destigmatize the word help, and it's okay. Like, that's the biggest thing, because once these people reach out for help, they're just like, man, I should have done this a long time ago. But I'm sorry, I feel like I'm going everywhere now.
Thank you. No, that's great. Thank you.
I think one of the bigger ones would be that addiction is a choice, like it's a moral failing, and that it's just as simple as stop using drugs. A lot of people that have not been in addiction might not know what it's like to get out of addiction. I mean, I know that most of the time I was in my addiction, I wanted help and I wanted to quit. I tried numerous times to. I didn't know how, and I'd always end up back in that same lifestyle because I wasn't working on my whole overall wellness. I was just focusing on not using the drugs that I was using. So I think that's one of the larger ones.
Thank you.
I think as someone who was struggling, I always had this misconception that once I got clean, I would still have a life that was still just kind of boring and sober and straight edge. And turns out I have an awesome life being clean. Like I've done so much cool stuff, and I've still achieved a great amount of success, and anyone else can do it too. It doesn't matter what you've been through.
For all of you, what role did peer connection play in your recovery, and how has that impacted others that you've worked with in your jobs? So it's a two-part question. How has connection played a role in your recovery? We'll start there, and then I'll ask the second one.
So you don't forget.
For me, peer connection really started about almost 2 years into my recovery. I was kind of white knuckling it before that. All I was really doing was going to the gym because I was avoiding everybody because I would go back to the same people, places, and things. But once I found Serenity Recovery Connection, I actually started volunteering there, and I had no idea really what a peer recovery coach was at that time. But just starting to volunteer and go into that community really gave me some more meaning to my life. It brought a lot of purpose into a life that I didn't really have too much purpose in at that point in time. I found somewhere where there was people that had gone through similar situations as me and that were, all on the same path to support each other and other people. And there was trainings involved, and there's like credentials that you can get to do this stuff, and it just kind of amazed me. And while doing that, and it made me feel, built self-confidence, helped me build my self-worth up. And in doing that, I created a sober community around myself that I did not have before either. So I could finally just not get off work and go to the gym by myself, which is actually what I still do now that I think about it. But a lot of my best friends I work with or have worked with, and every day at work I've got supportive people around me, and it's an environment like I've never had before. And I don't know if there's really any other workplaces similar to that, but yeah, that peer connection, that's really how it served me the best.
Yeah, for me, much like Frank, when I got hired on the Face Together, I had no idea what a peer coach was. I applied for a project coordinator position, but my CEO was like, I'm going to offer you the peer coach position. I'm like, I have no experience. She's like, you have 20 years of experience. So, but now thinking back, and I didn't, kind of correlate, but talking with my brother, he went through the same thing as me. When I went through IOP, my therapist, who was our group leader as well, I got fortunate enough to, get teamed up with him. Because when I went into my treatment program, I said, because I knew I'd get 1 hour of therapy a week as well. And I wanted someone, that was similar to me, similar in age, been through the same thing. So my therapist and, group lead, he was in his 30s just like me. He struggled with alcohol just like me. And I honestly feel like that's why I was successful in my program. Yeah, they can teach you everything you need to know in IOP. Well, not everything, but they can teach you a lot of tools and give you the tools in your IOP program. But having that connection with my therapist, I think that's truly why I'm able to say I'm still 4 years sober. But yeah, so and then getting into the peer coaching role and learning about what it's like, Frank said, getting certified, nationally certified peer recovery support specialist, NCPRSS. It's a ton of letters, but just having that, and then being, it's like I never thought I'd have any of this, and like I said again, I never thought I'd be sitting here on this stage right now. But it's just the peer support is just so impactful.
I love that we have so much peer supports these days. I'm going to sound like an old guy up here. Back in my drug using days, we didn't have peer coaches, but no, but we had. Yeah, I know I'm really old. So, but no, connection is super important in any type of mental illness or addiction. And for those of you, some of you have probably seen this YouTube video. It's from Johan Hari, I think is his name. It's called "Everything You Know About Addiction Is Wrong." And it's a great TED Talk about the importance of connection in helping someone with addiction. And so just that word connection is huge. And for me, I didn't communicate well at all as an addict. I had really bad psychosis from meth. It's a miracle I'm even up here talking right now, because when I was in meth psychosis, I was completely paralyzed and I couldn't even communicate. And when I would communicate, it would probably come out sounding really funny or crazy. And so relearning to communicate with people and connect with people is absolutely paramount in my recovery.
Thank you. The second question is a little bit more specific in your work of how has connection impacted others. So is there a story you'd like to share of somebody who is in recovery or that you have worked with in the past that shows the impact of connection?
Kind of similar to my story. When you're supporting others and you're using your lived experience, I think that the power of the peer is that we've utilized a lot of these resources, and how we found recovery we can share with other people in a very person-centered approach, because it's their recovery, but to help them kind of find their way to sustain recovery too. And with peer support, with how I've been supporting people the last few years, I've found that getting them involved and getting them connected and showing them that there is a world that you can be an ex-addict, I guess I could put it, and still have a normal life and be around others that will support you in that, and you don't feel judged. And in doing that, like I said before, it builds your self-confidence, your self-worth. When they get involved at SRC, you can be an engaged volunteer and get scholarships for the training program that we offer. And I think just doing that teaches you a lot about your recovery, and you have some skin in the game a little bit, and it engages you more, and you want to stay involved in that and support other people. And then in doing that, you realize that you're really working on your own wellness plan at that time.
You all don't have to answer this one. If you don't want to, it's okay. But if you have something to add to that, feel free.
Yeah, well, as we all know, addiction doesn't discriminate. I've had members that, are, homeless on the streets all the way to multimillionaires, and everywhere in between. But, like a story that always stands out to me is one of my members that I've been seeing for 2 years, and this roller coaster has been up and down. And I met her, she came to Faces Together right outside, or right when she got out of her treatment program. She was seeing one of our other coaches, both her daughter and husband were seeing one of our loved ones coaches prior to her getting out of treatment. And they were like nervous for me when she got out, because they didn't know how, everything would work, if she would even, be receptive of it or anything. So the first year of me meeting with her was, a lot of her lying to me, just saying that she liked vodka was her drug of choice, and it was, she would hide it a lot, and, have to wake up in the morning and have a couple shots, post-treatment even. So she went back into treatment, got well again for a little bit, still kept seeing me. This time she was more honest. But in her honesty, she'd come and sit on the couch in my room, and you could just see, just she felt defeated. You could just look at her. She's like, I'm never going to be able to do this. But me being Mr. Optimistic, I'm like, you're going to get through this. It's going to be hard. What do you think? What do you think could help you get to where you want to be? Being that mom that your kids respect again. Because she had some times where she embarrassed her kids at some dance meetings and stuff like that due to drinking. Well, So we kept going back and forth, thinking of, always her driving the solutions, not ever me being like, this is what you need to do. And, and I'm very proud to say that, just a few weeks ago, she just got her 1-year sobriety chip. And so just keep on going and keep on coming back. And, and if something's not working, try something different. And that's just one story I have, but that's just one, when you ask that, that's what always pops into my head. Because not every success, there's not success stories with everyone. Addiction's a very vicious cycle. But that is one that I'm very proud of, that, because she never gave up and I never gave up on her.
I think success looks a lot different for each person too. And I was just going over some of the people I've known over the years, and some I've coached and some I've had a lot of success with, and others the success does look like maybe they're just not going to kill themselves using drugs, and maybe they still drink or smoke weed on the weekends, but they're not killing themselves with heroin. Other people, it's like they have a great job, they start businesses, whatever, so it looks a lot different. But I've seen all of it and everything in between, and it's not a one-size-fits-all.
Thank you. Well, we are ready for the Q&A session. If you would like to submit a question, feel free to text that number. I've got my phone up here. They will be asked anonymously. And once I go through the text, then I will go around if there are any that you would like to just speak. Okay? Please hold. One of you had stated that, I believe it was Frank, or no, Eric, that what said enabling is a word to avoid. I think it was Frank. Why is that? And that could be for any any panelist, but why do we try to avoid the word enabling?
Well, I think, so I'll preface it with this craft group that I co-facilitate, stands for Community Reinforcement and Family Training. And it's like a 12-week group, and it's for the concerned significant other. And as we work through those 12 weeks, we're not trying to put any ideas in their head of what they might be doing wrong, or what, you don't want to tell somebody what they're doing wrong. Like, you don't want to tell a parent or something that they're enabling their child. Really, you want them to come to their own conclusions that might be what they're doing. So you kind of avoid saying that word enabling at all. And I guess I'll use the word motivational interviewing to help them develop their own discrepancies of, what's coming out of their mouth versus what their actions are with their loved one, and kind of guide them on their way to realizing that they might be enabling their loved one without, telling them that that's what they're doing, I guess.
So it's the approach more than the term? Yeah. Okay. Eric or Nate, do you want to expand on that at all?
Yeah, just like Frank said, it's just trying trying to use positive language, not using that word itself, enabling, because it has a negative connotation with it. And so, that's one thing, especially with craft. It's for family members, that are struggling, and they try to, use a different approach than's been used in the past, and, just trying to avoid the word enabling. They might be enabling, but we just don't want to call them out and say that's what they're doing.
Next question. If someone had been raised with verbal and physical abuse, which is so basically with trauma, how can a mother help their adult child after they've experienced that trauma?
Try to get them resources and try to talk with them to see what, I use the stages of change a lot to analyze where people are and wanting to get help. And so real quickly, that's pre-contemplation. The pre-contemplative stage means they're not thinking about making a change. The contemplative stage is they're thinking about it. Preparation is getting ready to go do something about your problem. Then action is, of course, doing that. And then the last phase is maintenance or termination or transmutation. And try to analyze where they're at in the stage of change and meet them where they're at. So if they're in the pre-contemplative stage, it's a very frustrating stage. They don't want help. They're not thinking about getting help. That's where you just talk with them and have a conversation with them, ask them questions. But hopefully we can get them to the contemplative stage. Sometimes just having a conversation, addicts do process things and they think about things over, sometimes it takes a little longer, but just a simple conversation could get them thinking about, wow, maybe all these things are causing an issue in my life and maybe I want to do something about it.
Thank you. Good. Thank you for the thumbs up. What should we be doing better to prevent youth from experimenting with substances?
That's a tough one.
It's okay, I'll give you a minute, 60 seconds.
I mean, because granted, none of us would be on this stage if we had prevention, right? Or a better form of prevention when we were teens. And that's the thing is like we're so reactive, and just naturally as a society, that's what we do. You know, okay, there's an issue, well, let's try to fix it. But I mean, prevention is huge. I mean, that's like, so like from a career perspective for myself, like that's what I want to get into, is like how can we prevent the youth from using, but I do not have the answer for that right now. But I do feel like there's something, I mean, that's where we need to put our focuses on, because if we can prevent the youth from, you know, experimenting or whatever it might be, then we can, you know, perhaps save a life or prevent them from going down, you know, the 20-year road that I went down, or, you know, where Frank or Nate went down. But I don't know, I don't have the perfect answer for that. But
I'd say education without the stigma. So proper education about addiction, I think, is the best shot we got at helping kids.
I also have found too connection, right, with an adult that could be that guide for them. Is that something you all have seen as successful? And how do kids get connected with those adults?
Yeah, so having like a mentor or someone, yeah, that's literally what our organization does, and I think that's one of the best protective factors for youth. Studies show that one positive relationship, just one, can change a kid's life. So that's a great point.
Next question, what specifically or who put you on the road to recovery? And I'm going to ask this to all three of you. So whoever wants to go first.
I think I mentioned it a little bit before. I don't think it's the one thing that made me realize, well, maybe it is, but it was the judicial system. And I don't put it all on that, because I had wanted to make change before that. But when I did get in trouble and was looking at a little bit of serious time in a state that I wasn't even from or have any family in, I had a lot of time to think in there. And of course, when I was in there, I'd do anything to get out of there. And I was in there for just the county jail for 8 months, and I got out and I started doing the same thing again. And just from seeing other people's lives around me and what had happened to them, and I knew that if I were to get in trouble again, that they would probably be like, my life was over pretty much. I was either going to be going to prison for a long time or end up dead. And it was kind of at that point, plus all the other things going on around me, like living situations and not having very many trusted people around me, and just living this lifestyle that was not me. I realized that lifestyle wasn't sustainable. And I think I knew that the whole time I was using, that it was only a matter of time before I needed to stop using. Like, I knew I couldn't do it my whole life, because if I did, it leads to prison or death. So I realized kind of at that time that my lifestyle wasn't sustainable, and I actually reached out for help that time. And I took the effort and made all the calls and did all the footwork to get that help. And I think having some skin in the game like that, I took all the steps necessary for myself to actually do that. And it felt great, and little by little my life started getting better, and I saw that those little steps that I took were actually helping me, and I was making progress, and it was probably the best choice I ever made.
Yeah, for me, the one person would probably definitely be my wife, Jenny. but along with her, I had 3 little kids as well, and I just was so sick of utilizing a substance to feel normal, to feel good. When I did go into treatment, like my use was very low. Like I should have quit drinking when I was 22. Like that's my rock bottom. But I went on for another 14 years after that. But it was just I always had to have a substance. Like we're out as a family. I'd have to have a beer, or out to dinner, I'd have to have a beer, or whatever it might be. But, because then I always justified my use. Like, on the outside, probably thought, most people probably thought I had a really good life. Like, I had a really good job, I had a really nice house, I had a nice car, I had a boat. So life on the outside, was good. On the inside, my marriage was crumbling. My relationship with my children wasn't as good as it should be. So it's just, just after... and like my daughter Brooke is back there in the back. Sorry, Brooke. But, she's seen me pass out on the ground. She's seen me in my worst. And I did not want to be that guy anymore. I didn't want my kids to ever, and both my oldest kids, my 13-year-old daughter and my 11-year-old son, saw me that way. My youngest daughter, that's 6, hasn't, but I made a, I made a commitment to myself that my youngest daughter would never see me that way. So, but I have to, thank my wife for, because she's been through a lot, and we just celebrated our 15th wedding anniversary 2 weeks ago, and I don't know why she stuck with me, but for some reason she did. So I'm just thankful for that, and I just wanted to be a much better husband and dad.
I think it was a few different things for me, and I think it probably is for everyone. I know there has to be a sufficient amount of pain or discomfort, which isn't hard to find in an addict, to want to change. And then there has to be kind of a catalyst, and much like Frank, I was highly encouraged by the judicial system to quit using. So my psychosis, my methamphetamine psychosis made me really uncomfortable to the point where I was sufficiently horrified to where I didn't want to continue doing that. My probation officer was kind of the accountability to say, hey, you need to move along, you need to get a job, you need to stay out of jail, you need to stay clean. And then my family would have to be the accountability after the fact that kind of kept me going in a maintenance phase, because I had kids around and I had to be accountable to them. And yeah.
Thank you. Next question. Not because we're in a church, but what impact, if any, has the church or your faith influenced your journey? Good PR, bad, or not at all? And you all don't have to answer, it's just whoever is comfortable.
I'll be 100% truthful. Faith has been huge in my recovery. Like we were talking about earlier, the multiple pathways of recovery. Some people believe faith helps them, and some people believe it doesn't. And for me, myself personally, it's been huge for me. Like even just moving from Minnesota to Colorado has been, if I didn't have my faith, I would never be here. I'd never be in this state. I'd probably never find recovery. So for myself, it's been huge.
Thank you.
Go ahead.
I don't know what this means.
Is he going? I'd say all of the above. So I have a very strong faith now, very strong belief in God. But when I was younger, the stigma in the church wasn't necessarily helpful to me. So I was very resentful of God himself and the people in the church and my parents and everything else. But again, like I was saying earlier, some of that's my perception. It's not all in the church. That was me being defensive about my addiction. And yeah, there's probably some truth in there. I think maybe I could have been approached differently on some things, but I've had experience with a little bit of all that. But in recovery, I can tell you that it is my belief that there has to be some component of spirituality or faith, or there's got to be something more you're fighting for in this life, or believing in.
Thank you. Next question. What suggestions do you have for family members who are trying to rebuild trust with their loved one as they enter into recovery? And that could be for anyone. What suggestions do you have for family members who are trying to rebuild trust with their loved ones as they enter into recovery. So I think it's asking if the family members who are struggling with addiction are trying to rebuild trust with their loved one as they go into recovery.
I mean, if I use like my own lived experience on that, I mean, I pushed my family away for years and years. I moved to a whole nother state, and I didn't even like to answer my phone just because the sound of my voice, they would know that I was using, and I was going to lie to them about it. So rebuilding that trust is huge, and that's what, you know, everybody, I'm pretty sure everybody wants to do in recovery, and that's one of the biggest things that makes us feel shameful about our use and what we did and our addictions, and trying to make amends for that is difficult, and people avoid it all the time because they don't know how to do it. For me, what I had to do really is just take the steps for myself to prove to myself that I wanted it I wanted this recovery for myself, that I wanted a better life, and I was doing it for me. And in turn, in doing that, things just kind of fell in place for me a little bit. My family saw what I was doing. You know, they started to believe what I was saying more. They wouldn't accuse me of stealing things anymore. You know, it's really just proving to yourself and showing yourself that you can do it. And by doing that, everybody on the outside, family or any relationship, is going to notice the work and effort that you're putting into that. And it might be really slow, and you might not realize it that much, but things start to work out when you're making the right decisions. Yes.
So we've come to the end of this panel discussion. I just wanted to thank Nate, Eric, and Frank for sharing and being vulnerable with us. Hopefully you'll all stick around for maybe lunchtime. So if people here want to connect with you one-on-one, that would be awesome. Any other questions that you have? I guess you just have to wait for lunch to talk to them. But thank you for submitting. Yeah, go ahead.
He really likes to do the weights because he's figuring out that sometimes it's a real challenge, and Nate helps him push through that. So having that person there to help you push through, and he's getting it.
Yeah,
Thank you for sharing. I love
That's
that.
great.
Thank you.
I am so sorry to have to cut this short, but we have to get the next panelist up. But thank you all so much. Round of applause for our panelists here today. And you may leave. I'm just kidding.
Fantastic job.
Thanks, guys. Thanks for coming. You did it. Yes. Yes. Is that your cup? Is that somebody's cup? Good to see you. Yes, if you believe me, that's actually not contagious anymore. My membranes are trying to recover, but I'm fine. Yeah, I'm good. Yeah, I'm excited to be here.
That one may not work. You may have to use this one, okay?
Yes. So we're going to get started in about 5 minutes. Actually, 2 minutes. We're going to get started in 2 minutes. We're running a little bit behind. Understood. I will make sure they know. No, I understand. Okay. Okay, I'll let them know. Yes. I will make sure nobody takes it. They should. She's on it. Test. So she's gonna like watch. All right, we're gonna get started on the next panel discussion. All righty, I don't talk very loud, so bear with me. Again, my name is Ashley, and I'm with the Teller County Mental Health Alliance, for those of you just joining us. And the second panel is going to be about adverse childhood experiences. Another word for that is childhood trauma and how that impacts our lives today. So the CDC's Adverse Childhood Experiences Study, or the ACE study, uncovered a stunning link between childhood trauma and chronic diseases that people develop as adults. This includes heart disease, lung cancer, diabetes, and other autoimmune diseases, as well as depression, violence, being a victim of violence, and suicide. The more adverse childhood experiences or childhood trauma that someone has experienced, the greater risk of encountering challenges later on in life. However, with the right support, interventions, and resilience building strategies, individuals can overcome those effects of childhood trauma. We are here to talk a little bit about adverse childhood experiences and what we can do to help buffer those effects of childhood trauma. And joining us as panelists, we have, starting with Meredith Schumann, is the founder of James Trail. If you could raise your hand for me. She is an organization supporting the unique needs of families and organizations impacted by trauma. She has over 28 years of experience serving as a therapist, trauma-informed trainer, and as a mom. Meredith holds a Master's of Social Work from the University of Texas at Arlington and is a trust-based relational intervention practitioner. She and her husband, Dan, a global health physician, have been married over 30 years, and they have 5 children, 4 of whom are adopted. Meredith loves a passport with lots of stamps, a water bottle with lots of stickers, a table with lots of people, and a mountain with lots of trails. So she's in the right place. Thank you for being here, Meredith. Next, we have James McLaughlin, who is the director of the Community Paramedicine Program of Ute Pass Regional Health Service District, and is affectionately known by most within the community as Tiny. James has been involved with emergency medicine since 1991 and has been honored to serve the citizens of the Ute Pass Regional Health District since 2008. James has helped to create the Teller County Mental Health Alliance and has sat on the advisory board of the Alliance since 2018, has played a pivotal role in all of the work that we do in Teller County for improving behavioral health. His vision and determination have led this collaboration to its success today. James is the father of 4 amazing children, 2 precious grandchildren, and 1 precious grand puppy. In his spare time, he likes to travel the world on a shoestring budget, often staying in hostels, vans, and on one occasion, a train station. James has been to 16 countries on 6 continents, so very worldly and well-traveled. Next, we have Joyce Aubrey, who's the founder of Finding Our Voices, an organization that provides support to survivors of sexual violation through our activities and gatherings. Joyce is an award-winning author of the book Beyond Aftershocks, Reclaiming Self After Sexual Trauma, which captures her struggle to believe the flashbacks when they occurred later on in life and how she rose above that crisis. She has been using the Adverse Childhood Experiences study and follow-up information and working with trauma survivors for 16 years. As a vociferous reader, Joyce has extensive knowledge on follow-up research relating to trauma. So welcome to our panelists here today. Thank you for being here. And I'm going to go sit in my chair because this is uncomfortable up here. Please hold. And there's another microphone.
Test.
Since we know Joyce's microphone works, I'm going to ask you the first question. Actually, no. I'm going to ask James the first question because it's a foundational question. And some of us may not understand what adverse childhood experiences mean. So can you give us a summary of what is considered adverse childhood experiences, the study, and its findings?
Yeah, so throughout history, we started to notice differences in people that had had events in their youth, in their childhood. And then psychologists started to study that quite a bit, and they looked at how decisions are made and how our mind processes decisions. And what they found is when you're exposed to certain childhood events during those formative years, during those developmental years, it changes the neurochemical makeup of your brain. And it actually slows progression of development of your prefrontal cortex. And the reason the prefrontal cortex is so important is because when we're put in an excited state, our body releases epinephrine, right? We have these adrenal glands sit right on top of our kidneys. Epinephrine gets released into our bloodstream, and that changes how our brain processes information in the now. We go from our neurocortex down to our limbic brain. That's the middle of our brain, right? So think about the top of your brain is like the outside part that does all the really cool creative stuff. It allows us to comprehend what we read. But have you ever been in a stressful situation and you're reading a book or you're reading something at work and you realize that you've read the same thing 5 or 6 times and you don't have any idea what you just read? That's because you are not operating in your neurocortex. You're actually operating in your limbic brain. And when you have critical decisions to make in that moment, what happens is when you get into that limbic brain, you depend on previous experiences and the knowledge of those previous experiences. And most of us, when we get into a high-stress situation, when we've had well-adjusted childhoods and we haven't been exposed to trauma or abusive situations, our prefrontal cortex is well developed, at least by the time for men, or for women by the time you're 18, because it starts about 16, ends at about 18. That prefrontal cortex really starts to develop and mature. And then for men, it starts at about 18 and ends about 25. Explains a lot, right? So, but what that prefrontal cortex does is when we get into that limbic brain, it gives us previous experiences to tell us that we're going to be okay, that we're going to survive this, that we're going to make it through this, because we have before. But if you don't have that to draw on, then it's easy to get to have significant responses that seem inappropriate for the situation. But when you've had those traumatic events and the prefrontal cortex isn't there to guide you and support you. So they did a study, and it's the ACEs study, and what it found was that if you had a combination of adverse events in your childhood, you were more likely to have and suffer consequences later in life associated with that. You were more likely to struggle in school, more likely to struggle in life, more likely to struggle financially, because you don't have that prefrontal cortex to draw on when you get in stress. We're all going to find situations that we're stressed, right? And so, and I'll wrap it up with this. Some of the things we're talking about are child molestation, right? Abuse, neglect, isolation and loneliness. Not loving a child is destructive. Homelessness, exposure to structural inequities. So those kinds of things erode the foundation of safety that every child deserves and corrupt our development process. Does that answer your question?
Thank you, yes. Joyce Meredith, would you like to expand on just some background information on the study?
Well, what I'd like to say, is this carrying through?
Yes.
Okay. The thing that I have discovered in using this with sexual abuse survivors is that a few of the people we work with have heard about it before we talked about it, and they already have decided that they're damned, they're doomed. And you need to understand that the study does show us some statistics on what may develop, but it's not a predictor. It's like warning your child, you know, guess who this morning came off without a raincoat? The blinds were down in my house. I got halfway across town and I realized, oh, I should have brought a raincoat or an umbrella. Well, we watch the weather report or we look outside the window to realize how we can prepare ourselves. The same way if we have cancer or heart conditions in our family, we know how we can reduce the risk. And that's what this can do for people who have experienced trauma. It's really important that before you ever administer the test or the survey to anyone, that you make that very clear.
Thank you.
Yeah, so there's a lot of different responses that can happen from this test. Can I just take a moment and say, who's loving the weather right now? I mean, can we just like be super happy about that? Thank you. There's a lot of different responses. As many as there are people that have taken the test, could be that many kinds of responses to the your test results. So you could see it as, yeah, oh, my life is over because of this, now I see the score on this test. Or you could, come from the other angle and say, oh my goodness, that explains so much. That actually helps me to understand why some of my responses for so many years has looked like X, Y, Z. And so one of the things that I'm sure we all would agree on is that as people, administer this test or are taking this test, that the administration of resources along with the test is absolutely critical. Resources to help each test taker, each recipient of those results, to be equipped to know how to move forward with whatever their results are. Yeah.
Thank you. When we're talking about a test, it's nothing scary. It's a 10-question questionnaire, essentially, that is asking you if you've experienced one of the following 10 things before the age of 18. So it could be, have you experienced neglect? Have you experienced a family member in the home who struggled with mental illness? A family member in the home that has been incarcerated? So those are kind of the questions that are asked, and there's 10 of them. And your ACE score is determined on how many you answer yes to. And so the higher your ACE score, the higher risk you are at of experiencing adverse health effects later on in life. And again, it is not a determinant. It is not to say you are definitely going to experience health problems. It's just, it's something that we can do as a community, but also as a public health agency generally. Like this is the biggest predictor of health outcomes that we have, and there's something that we can do about it. And so we're going to talk about that a little bit more. I'm just trying to get my bearings here. If comfortable, can someone explain or briefly share some of your personal stories of childhood trauma and talk about how those experiences impacted your health later on? And that can be for all. So James, we'll start with you.
Yeah, I was actually going to do that anyways, so thank you for creating a space for that. And I'm pretty open with my experiences growing up. I am a survivor of childhood sexual abuse. So I was abused by somebody for many years who was in a position of trust and wasn't believed. And I was very angry when I was younger, and I had, as I grew, I had a lot of mistrust for the system because I felt like the system had let me down. But I always intrinsically believed in myself. I genuinely believed that I was going to rise above where I was. And I think that hope was the resilient spark that helped me find, because I didn't do it alone, right? We don't do these things alone, but I had that resilient nature, that intrinsically resilient nature, and other people saw it in me, and that encouraged other people to step up and want to support me and want they saw this thing in me and they wanted to be there. And to this day, there's people that I call my birthday's coming up on October 22nd, in just a few days. And every single year, I call those people and I tell them how much their small action to them has impacted my life in such a meaningful way. So I want to echo what these two say. Those experiences don't define who we are.
Can I get an amen? Somebody, we're in a church, y'all. All right.
Thank you for sharing, James. Thank you.
That was beautiful.
Thank you, guys.
I could respond to that as well. I was a subject of incest and family trafficking from toddler to teens. So it wasn't just every member of my family that violated me intimately, but my body was shared with the preacher and soldiers at Fort Riley. I didn't remember any of it till my mid-50s, which Child USA in their research tells us that mid-50s is when 9 out of 10 children seek survivors of childhood abuse will seek help, so I'm not unusual. I am unusual that I'm in my mid-80s, and since I experienced 8 of the 10, my life should be shortened by at least 20 years. I think I've already beat that stat.
Let's go.
And for my experience, I had an aunt who was always very sensitive to my crying in the corner and sucking my thumb. And then as a teenager, I had a ruptured appendix, and the physician who saved my life in the 50s, that was a death sentence, did not stop there. He had his wife call my mother out on the farm and convince her they needed a housekeeper. And that doctor's family saw me through high school, saw to it that I went to college. They didn't pay for it, but they took me down for entrance exams. She came down and bought me clothes. He came down and bought me dinner when I flunked a test. And so I ended up with two degrees, a bachelor's and master's degree, had very successful careers
teaching, counseling, and then as a retail merchant before I had my memories. Then, like everyone, thought I was going crazy, so I left a 35-year marriage. I left a 23-year successful retail business where I was one of the top sewing machine dealers in the United States to start over again. And it was the best thing that ever happened to me. The Peter Levine, Besser van der Kolk, Gabor Mate, all of those people tell us that it's not what happened to us that determines whether we are negatively impacted forever. It's how we think about it. And so I think I had enough people on the fringes loving me and protecting me that I could come out of all of that and live an abundant life.
So my story briefly is that I grew up in a household with a mother who had extreme mental health issues. And so you can imagine the different things that would have gone on. And she died in 2018 of Alzheimer's. And that path has continued on even after her death. And if you know and experience a story similarly, then you can relate. And then we have, as she mentioned, we have 5 kids. 4 of them are adopted. And the younger 3 were adopted from Colombia at an older age. And we just celebrated what we call Gotcha Day 17 years ago. So our girls are in their young adult years now, but they came with experiences that is the worst that this world has to offer. And they came and it all spilled out into our family. And what I didn't see coming was how I had done a lot of work to overcome some of the challenges of my childhood. But then when we adopted our girls and their trauma started to unfold in our home, then I was taken back to areas of my life that weren't really healed. They were healed to some degree, but I'm a person of faith, and so sometimes I speak in ways of faith. For me, I believe that Jesus was helping some of those issues to bubble to the surface because he wanted to bring healing in that. And so that's part of our journey, and that continues because even though my mom has passed, I'm still processing some of that. And for sure, our kids are still very much in our lives. And their challenges persist and don't get easier in adulthood. Do I hear an amen? Yeah. So, so that's some of my story.
Thank you for sharing. An experience. I just wanted to share a personal experience with it too. Before I learned about adverse childhood experiences and childhood trauma and how that affects, I thought growing up that I had a good life, great parents, all of the things, and I realized that there was a parent's mental illness in the home really impacted me as an adult, and in my anxiety and my people pleasing and all of the things. And once I realized the connection, I was able to give myself grace of like, oh, this is why I try to do this all of the time. And it really helped with the healing piece of it too, is understanding why. And I know that when I teach ACEs too, I see that especially with parents, because that comes into parenting too, right? Our past comes into how we parent, and I see parents all the time, the light bulb goes on and they think, wow, this is coming into my parenting now, and how I have been impacted by childhood trauma. So it's just interesting, the connection. How how prevalent is childhood trauma? Because some of us in the room might feel isolated in what we've experienced, and I think it's important to talk about how common it actually is. And this is for anybody.
I can't give you statistics. I'm not prepared to do that. But what I will say is I can tell you anecdotally that on the community paramedic side, most of the persons we come in contact with on a daily basis have been touched by childhood trauma of one form or another. But I would also say, and again, this is anecdotally, most of the providers that are out there doing this really hard work are driven by the fact that they are survivors of childhood trauma themselves. And it's what gives them the ambition and the drive and the tenacity and the compassion to do the work that they do, because they know how important it is.
I could share a few stats. For one thing, we know that complex PTSD develops if there is repeated traumas. And the statistics before COVID was that approximately 1 out of every 4 would develop negative consequences later in life. Now it's 1 out of every 3, because we've all been through the trauma, the increased trauma of the COVID epidemics. We also, most people who work with sexual assault survivors now say that 1 in every 5 adults has experienced some type of sexual violation. And that may include exposure to pornography, molestation, or rape, incest, date rape, and all of those things. In my 30 years of being shoulder to shoulder with sexual abuse survivors, I'm well aware that it's frequently intergenerational. And I think that's something that most people don't realize. And even in my mid-50s, when I started talking about my abuse, then I learned, oh, I was not the only victim. And as I talk with other people, I find similar situations. And also those of us who were abused as toddlers, it's not, or as children, it's not unusual to re-experience abuse later in life. We joke about thinking we have a sign on our head, but it seems to be something that energetically happens, whether it's because of our own, the way we project ourselves, or what it is, but it is not unusual for a sexual abuse survivor to recount more than one instance.
Thank you. I think something that's really important to be aware of is that there's a comorbidity or a correlation from 1 of the 10 to having more than 1 of the 10, right? So, for example, if you look at the 10 categories, it does include family dysfunction, some form of sexual abuse. There's a number of categories within these 10 questions. And so let's just walk through a scenario real quick. So let's say that hypothetically, not using my own story, but hypothetically, let's say that there's perhaps some mental challenges, maybe a mental health diagnosis that's not diagnosed, going on in a parent, okay? With a child who's, say, 3, 4, 5, 6, 7, something like that. And because of this mental health challenge that the mother is facing, let's say maybe she is self-medicating. So maybe alcohol, some sort of substance use, anything like that. Okay, so that's now, you've got mental health and you've got substance use happening in the home. And let's say because of the substance use and the mental health challenges, maybe the mom doesn't feel worthy or she doesn't feel like strong enough to have healthy male relationships. And so she invites men into the home that are not healthy for this 7-year-old. And let's say because maybe that man has had his own ACEs, his reactions to the child is abuse, either physically, sexually, emotionally, or otherwise. So do you see how quickly you can grow up and have a score of 4 out of 10 ACEs? Now, as far as school is concerned, that sounds like a low score. But the thing is, the statistics show that if you have 4 or more ACEs, then the impact on your physical health, it increases, all kinds of challenges, hypertension and diabetes. And my colleagues here could speak more about that. But let's look at this room right here. It's let's see. So if I'm getting the stats right, you guys correct me, okay? It's 1 out of 5 or 6 has an ACE score of 4 out of 10. Is that what we know? And so in this room of, what do we have, like 30-ish, 20 people, there are easily, 6, help me with math here, y'all, 5, 6-ish, maybe more people in this room who've experienced 4 or more ACEs and have experienced the cascading challenges that come when you have just one. And so that's why those, correlating the score to the need later in life is really critical. And again, the response to that is, we hope, because we're here because we have hope, right? We've experienced victory in our lives. I know I have, or we probably couldn't stand up here. And so there is hope, but we need each other, right? We need community. We need to come alongside each other. And so that's part of what's beautiful about this symposium. And we hope that if, we have it again someday, that you would encourage people to come, because this symposium is about education and hope. Are you guys feeling me on this? Okay, thank you.
I'm so glad you brought that up, because there are categories of resiliency. And I gave a class just a week ago on post-traumatic growth. We now know that there is a possibility, there is a good chance of post-traumatic growth, and it's based on resilient factors. So I brought my handouts that are left over from that experience, and I'll be on this side after we finish this panel. And I have copies of the ACE 10 questions. I have copies of 2 different resilience surveys, because that's all about informing yourself. If you have 3 or 5 or 7, how many you have is not the determining factor, but the determining factor is how you think about it and the actions that you take. I always tell my people, the last step for me in post-traumatic growth is living by your internal GPS. And if you listen to your gut, it gets louder and louder, and you're sure of it. And people will say to me, but I never know if it's intuition or if I'm just dreaming. That's because you're not listening to it, or you're not taking action on it. Because if you do listen and you do take action, you will become more confident that, oh, I just got the message not to drive home the normal route. There must be an accident.
Thank you for that. And Meredith, I want to kind of elevate something you said that I think is really important. You kind of hit on the edges of it, and that is hurt people, right? Like, no one is all good or all evil. We all can be not great at times, and we can hurt other people. And we all, no matter how how often we do that have the capacity for great love. I'm religious as well, and I believe that's given to us by Christ. But I think the key why ACES is so important is because it gives us an opportunity to identify hurt people and to provide them with the amazing work from wonderful people that can touch them in meaningful ways, touch their soul and their spirit in meaningful ways, and begin that healing process. And no healing process can start without at first being able to acknowledge that the injury is there.
Thank you. Y'all are showing me up, man. I'm just here to ask questions, and yeah, okay. I'm trying not to connect in too much because I will start crying. When we talk about childhood trauma, what are some things that come up later in life in terms of activating factors? And I'm saying that in place of triggers, just because I'm in suicide prevention, and triggering is not a word that we want to use. And so when we hear the word activating, that's what I'm talking about. Okay, I just wanted to let the audience know. What are some of those activating factors that come up or have come up for you, or that you've seen as triggers?
Well, the fact that traumatic memories don't go to our hippocampus, where we have the access codes. So it goes to where we have fight, flight, or freeze. So we're going to be triggered by our five senses. We're going to be triggered by smells, by sounds. For me, there was a word. And so we don't access our trauma in the same way. And there's no information code that comes along with that trigger. If a smell triggers us, we just know we're triggered. I could not stand Clorox. I had no idea why, but it was never in my house. And if you read my little companion book that's written in a child's voice, good reason. My mother cleaned me up with Clorox in the water. It was a trigger for 50 years before I knew why.
I think one thing to understand about activation is, we live in Woodland Park area, right? Or at least, I don't know, how many of us are from Woodland? Okay, how many of us are from outside of Woodland? I'm actually in Cascade, Colorado Springs. Is everybody, we're in bear territory, right? Okay, so let's just say if a bear were to walk in the sanctuary, which, we'd all have a moment, is what I call it. We're going to have a moment. And if a bear walked in, we would have basically those three responses: fight, flight, or freeze. Somebody would be throwing chairs at it. That's the fight. Some of us would be like, okay, is that door go anywhere? We would be fleeing. And some of us would just kind of. So that is the response, because in the moment, the blood starts rushing to the back part of our brain where we don't have access to our prefrontal cortex as much to make those decisions, okay? That's how God made us. It's like a really great way to get us out of trouble in a moment. But what if, hypothetically, I'm 16 and my abuser walks in? So nobody would judge us if a bear walks in and we're freaking out. Our heart rate is up, we're having fight, flight, freeze. Nobody would judge us. So why would we judge the 16-year-old when the abuser walks in and her brain is literally doing the same thing? Her brain is in fight, flight, or freeze. I call it fear brain. Her brain is literally doing the same thing. So why would we say, calm down? Just calm, you're fine, calm down. You're overreact. Exactly, you're overreact. That is the activation.
Hysterical.
Right. Instead, this is part of what's beautiful about a symposium like this, is we can come alongside each other and ask curious questions. Asking questions like, are you okay? What's going on?
And to tie into that, it doesn't have to be the victimizer themselves that comes in, the assailant themselves. It can be someone who comes in that has a similar smell. Remember, olfactory sense is the one greatest tied to our hippocampus, right? To our memory. So smell, maybe they have a similar jacket, maybe they walk in a similar manner, maybe they say things, maybe they have some of the same controlling behaviors that that person had, some of the same manipulative behaviors that that person had. The voice, the inflections, the tone, the depth of voice, the sound, any one of these things, because it only takes one thing to go, and then you can instantly be back in that moment. Now, there's things you can learn to manage that, but you got to know that it exists first, and to do that, you have to create. And I know this word gets. It's been turned into a joke in a lot of ways, and it frustrates me because there is a meaningful use for it, and it's important to make it safe for people to have those experiences. It's important to understand that it is okay to have we don't have to understand what someone's going through. They're the expert in their experience. We just need to come alongside and support them.
Thank you. Thank you for answering that. One of the responses that I wanted to just talk about really quick is the fawn response. Do you have familiarity with that, or could you explain it? Because I experience that all the time.
We used to just say fight, flight, or freeze, but now we say fawn, and that is when you acquiesce and get along with whomever. And it served me beautifully in 23 years as a retail merchant. Everybody was always right, and I was always wrong.
FAWN, so fawn response. And the way it shows up for me is conflict makes me very uncomfortable. And I will do whatever I need to alleviate that conflict or to make others around me feel comfortable. And I didn't realize that that was a trauma response until my 30s. And I'm starting to give myself grace in that of just like, it's okay. And I can work on it. But it's going to be a journey I'm on for the rest of my life. And so that is one that's represented, I think, too, is we see a lot of, for example, in the classroom, there's a student that is getting good grades but is quiet in the back of the class, and they're not a behavioral issue, but they still might be struggling with trauma. And so we can't forget about the kids that are sitting in the back of the room and doing well, right? We have to be checking in with them too. So I just wanted to bring that up too as another branch of that.
Yeah. Can we do an exercise? Do we have time to do a quick exercise?
We have 1 minute.
Okay. We're going to do a really quick exercise. Close your eyes for just a second. Think that you step into an elevator. All right, you're in this elevator. It's going up to the 50th floor. You get in. There's no one else in the elevator. It stops at the 10th floor. The doors open up, and somebody else hops in that elevator with you. They're a stranger. You don't know them. They seem somewhat intimidating to you. You don't know why. Think about what you would do at that moment. Would you move against the back wall? Would you give them a big, broad smile and show them your teeth? Would you start chatting with them just to have them talk back to you because you believe that if you start that conversation, that creates safety? What would you do in that moment? This is an exercise. You can open your eyes now. This is an exercise they use in a book called Games That Primates Play. And it is human nature. Most people will move against the back wall and will smile. And that's the exact same thing that two primates will do in a cage when they're in a cage together, because the risk of them having confrontation is the outcome is going to be negative for both of them, right? But when that prefrontal cortex is damaged, And when that neurocognitive response is damaged from trauma, you may have a hypervigilant response in those situations. And it takes time to heal.
I'd like to share the 5 steps of post-traumatic growth that I use with our group. They come from Linda Graham in 2017, and you can find as many as 15 steps online, but I'm old and I can only remember 5, and my people can too. The very first thing you have to do is get beyond denial and minimizing. So you have to recognize that you did, yes, experience trauma. The next thing you must do is get it outside of yourself. You share it with someone who's safe. And Brene Brown tells us, you share your story with somebody who's earned the right to hear it. Then the third thing you do is look for the lessons learned. You may be more vigilant, you may be wiser about some things. Certainly you will have learned some lessons from your trauma. The fourth thing you do is establish a new paradigm of who you are that includes your native, intuitive, God-given talents with what you have learned from your trauma experience. And the very last thing is to live by your own internal GPS. That all requires safety before any of those things can happen. So you mentioned safety earlier, and I don't want to neglect that.
Thank you. Well said, yes. I don't want to rush, but we do have some questions coming in. And if there are questions for the panel, please text them or raise your hand after this one, okay? This is for all of you. What happens in a person's mid-50s to resurface repressed memories?
Well, in my experience in 30 years shoulder to shoulder with survivors, it's frequently a traumatic brain injury, an automobile accident or a fall, a ski accident, something like that. For me, it was physical health declining after I'd always been healthy. But for every person, it's different. It may be an illness. It may be a marriage breakup. It may be loss of a child, tremendous grief. Something triggers our system so that that memory that is in the amygdala, where we don't have access codes, makes its way into the hippocampus. And for most of the people that I hear from, it starts with nightmares. I had 3 reoccurring nightmares that my partner would wake me up at night because I was screaming and kicking. I had those 3 recurrent nightmares for more than 40 years. And I've never had them since I've cleared up my memory. And after you have kind of strange nightmares, then it may invade your conscious thinking. And eventually, you feel very crazy if it's a matter of repressed memories. Most everybody who I've worked with that has repressed memories goes through a period of feeling like I'm losing my mind. And I used to say, God, let me know. Just let me know when I've gotten so far gone that I'm dangerous.
And another, obviously not with the panel up here, but another contributing factor can be that as you get into your 50s, you start losing more neurons over time. And so the way the neurochemical processes, they create pathways and signals. As those pathways and signals start to break down, your brain has an amazing intrinsic resilience that will create other pathways and signals. And those additional pathways may, I say may, make new connections that connect you to thoughts and memories that you previously just weren't aware of. So it's kind of a double whammy sometimes where, you know, we do have folks that are in cognitive decline and simultaneously they're starting to remember some of these traumatic experiences that they've had in the past. And what makes Colorado so rough is that there's very few geriatric psychiatric facilities to provide services, or very few geriatric psychiatric providers. And so often they just want to put that off on it's a cognitive decline thing. It's only a cognitive decline thing, right? And they put all these barriers in the way for people to get access to care. And I will tell you, if we come across someone who's greater than 65, who's in behavioral crisis, and our mobile crisis response team responds on them, it is nearly impossible to find placement for them. And that, to me, is darn near criminal. It's not right.
I feel like I'm losing brain cells every day. Anybody? Yeah. Yep, that's me.
Next question, how do symptoms of trauma change after seeking help? How does symptoms of trauma change after seeking help?
Well, for me, I understood why I fear death at the sound of the F word. I understand why I can't stand Clorox. I understand why I can't stand Camel smoke. I understand why I can't stand Old Spice. So symptoms that make no sense at all make sense. And then you can do your grounding activities and your therapy to try to overcome responding in a panic to those triggers.
I'm a huge advocate for counseling and therapy in the right setting with the right person who's a fit for you and all of that stuff. And that person can be huge in helping you to connect those dots to where the activation and the moments of activation no longer have the same power over you. They no longer take you into, right? Into the physical responses, the elevated heart rate or the panic attack or whatever is happening in the moment. But, I mean, I will freely say I have been in and out of therapy for 4 years, and it's been awesome. Huge, huge point of victory for me. But it's also about community, and I know we've brought that up some here as well, in that having your people, if we need to find our people. And if you don't know, I love how there's padding, you're my people. That's so beautiful because we need our people. And it may or may not be our family. Yeah. Am I allowed to say that? It might be, I hope it is for you. And there may be parts of our family that are safe, but we need to find our people that, as my colleague has said, have earned the right to hear your story and will walk with you in it. So for me, another piece has been my faith, and leaning into that community for me has been people of faith and church, for me. And leaning into my relationship with Jesus has been absolutely transformational for me. And so the benefits when you get to the other side is that all of those things that used to take over my body and my life at the time don't have the same power over me anymore.
You brought up such an important thing. I was exiled from my family, birth family, and because I got divorced after 35 years from that family, and we have what we call chosen family in our sisterhood, where we support each other, and we do heal in community in so many ways. AA is certainly, and all the 12-step programs have shown us how successful that can be. And I think that in sexual abuse and domestic violence, people are encouraged not to connect with other peers in those two places because it seems to be common perception that that's going to make it harder. And so for 30 years, I have battled that myth that it's going to make it worse because look at the statistics, especially after COVID, of how many people in our world, in our country, feel isolated and lonely. And isolation is a normal response to trauma because you don't want to be triggered. So I'm going to stay in my house. I'm going to have my groceries delivered. I'm going to not go to the movie. I'm just going to watch it on TV. That isolation is deadly. We do heal in community. We need connection. We are wired for connection.
Yeah, I agree. And I think when somebody gets to the point where they ask for help, first of all, they've taken that first step. They've acknowledged that there's a hurt, right? We've discussed how important that is. So the first thing they do is they've acknowledged the hurt, and then the second thing they do is they take back the power, right? They take command. And it takes all kinds of forms, but they take back the power enough to say, I want help. I don't want to be where I am now. Just that action alone, in and of itself, is empowering. And I want to give a shout out real quick. I agree with what both of you guys said about the need for connection and connectivity. And that is the number one thing that I believe leads to ultimate healing is connectivity, finding your community. And if a faith-based route is the direction you want to go, I have to give a shout out to Celebrate Recovery. They are a phenomenal program, and they're there to support anyone with hurts, hang-ups, or habits. And that is their motto. So absolutely, we're very lucky for being as small a community as we are. We do have a Celebrate Recovery program. I'd be more than willing to share that with you afterwards. But you know what? If that's not your cup of tea, then 12-step programs like AA and other opportunities are out there. Keep looking. If you go to one and it doesn't feel right for you, that doesn't mean that you don't need help. What that means is you got to find the right help, what speaks to you.
And when people ask me, what can I do to support someone I love who's healing from trauma, the very first thing you can do is listen. Don't try to fix them. And there are so many, we all want to.
Amen.
There are so many trite things we can say, like, oh, this is just temporary, and don't choose a permanent solution for a temporary problem, or you're just making a mountain out of a molehill. Get over it. It happened a long time ago. Everything happens for a reason. Those platitudes are not going to help the trauma victim. What might help them is saying, I'm so sorry that happened to you. I believe you. What can I do to support you? And when they say, just listen, believe them.
Thank you. One more sentence, and then we're going to go to lunch.
Yes, thank you. So the organization that I'm a part of, called James Trail, is really has been birthed out of some of the challenges that I've talked about and that we've talked about today. And one of the things that is so important for me as a part of that organization is the name James and Trail. James is after some verses in the book of James, and Trail is, y'all, I don't got this figured out. Like, I'm not going to for 2 seconds sit up here and say, oh, my life is all together and everything's perfect for me. No, I am on the trail. I see you on the trail. Let's walk the trail together.
Well said. Thank you to the panelists. Hand of applause. Applause. Thank you for coming here and sharing your story with us. Hoping you'll stick around for people that want to connect individually. Meredith did bring some books that you may not take with you, but you can take a picture of them if you would like to read them. They're great. Yeah, they're a great thing to add and do some reading on if you wanted to explore some other additional things on how trauma affects us. So please don't take the books, but take a picture of them. Feel free to.
They can take a
Joyce
rack card.
has on this side. She's going to have. Are you going to have a copy of your book as well? Well, Joyce has written an award-winning book that she has in spirit, I guess. Yes. So if you give her your name, she will provide you with her book and information. She also has the ACEs questionnaire and the resilience questionnaire there too. If you're curious about what your ACE score is, again, totally up to you, but it's a good resource to have. It is lunchtime now, and you're going to go straight to where breakfast was served. And it's a time to relax, connect with each other, lay on the floor if you need to, but I will be checking on you if you're laying on the floor. Thank you, guys. We'll see you back here in 1 hour.
Ashley's going to serenade us all, I heard.
No. mean, you can stand up here with me if you want. That would be cool. Whatever seat you want to be at. It's totally up to you. Me too. And they can hear you. I'm the same way. And I don't open my mouth when I talk either. Yeah. And so, or enunciate well. And so if I'm talking to someone like this, they're like, what? I don't understand. All right, everybody, in the next 5 minutes, we're going to get started. I know y'all can hear me outside of the sanctuary, so that's why I'm announcing. Yes, please. Thank you. No, it's Saturday. You need to spend time with your kid. For real. I'm not mad at you. Well, thank you for being here and being a panelist on a stage. I appreciate it. But seriously, if you need to leave, like... Okay. Okay. Yeah. Did I get any soup on my shirt? Did I get any soup? Am I good? Cool, thank you. Thank you. I just kind of want to take a nap. Yeah. I love doing it. I love it so much. You guys are doing the hard work, sitting and answering questions. I'm just here to ask questions. It's okay. I just don't want you to miss anything. Oh my God. Are you selling them? Can I? Thank you.
Much better, thanks. Yeah, yeah. Little tiny, I've got 2 minutes.
Your body's like trying to flush it out, like get out of here. Oh, good. Okay.
I was like, she's almost ready to walk out the door, and I'm like,
If you can't breathe, you gotta get shit done. You need to be able to
breathing's
kind of. Yeah.
Has it been going okay?
Yeah, it's been going really well, actually. Really good. Good questions. Yeah, I feel bad for having the questions sent out to panelists like last minute, but yesterday was kind of crazy trying to get everything. Okay.
Hey, Shannon. Nice to meet you.
All right. I was going to say we're waiting on our last panelist, Miss Karen.
Yeah, awesome. Do you work with
That is your
Faith?
seat.
I didn't realize you were a panelist the whole time you were
Okay, everybody, we're going to get started with our next panel discussion about depression and anxiety. And I'm going to be introducing our panelists up here today, but people are going to be crawling in, and that's okay. So depression and anxiety manifests in many ways. We can often sense that there's something not going well for ourselves or someone we care about, and we may not feel that we're equipped to seek support for ourselves or provide support to someone we love. We're going to be discussing signs of depression and anxiety, answering any questions you might have about it, sharing personal stories about overcoming these challenges, and offering tools to take with you after today. Our panelists here today are, first we have Alan Katzen, who is a behavioral health clinician at Pikes Peak Regional Hospital. He's been a private practice therapist for over 30 years as well, so has extensive experience in that. Having lived in Teller County for the past 4 years, he's worked at Pikes Peak Regional for 2 years. Alan is also a member of the Advisory Council for the Teller County Mental Health Alliance and is actively involved in community initiatives, including the Shared Referral Task Force and the Lethal Means Task Force. So welcome, Alan. Thank you. We also have Shannon Johnson, who is a licensed clinical social worker, serves as chair of the social work department at UCCS, and regularly sees a handful of clients for mental health services as well. Shannon has lived in Woodland Park for 4 years and has 3 children. Her focus is in research and in practice is on trauma, teaching trauma-informed care in various settings. Welcome, Shannon, thank you. Next we have Karen Francis. As a dedicated advocate for special education, she has come out of retirement graciously to lead the Woodland Park High School SWAP program, and you will have to remind me what that stands for. School to Work Alliance program. Has been married for 47 years. She's a mother of 7 children, 4 of whom are adopted and have special needs. She is deeply committed to values of equality, fairness, kindness, and respect, and her life experiences have given her profound empathy and a deep understanding of heartache, loneliness, and self-compassion. Welcome, panelists. Thank you for being here. As always, if you have a question throughout the panel today, just please text the number that is going to come up now on a slide. Also, I can come around with a microphone and would be happy to do so, but just know as they come up for you, you can feel free to text that number with your questions. Okay. So this is a question for all of you. How would you define depression and anxiety? What are some things that we need to know about those conditions? And it doesn't have to be all, but I would love someone to answer the question. Alan will have the clinical side, yes.
Sure, I will go first. There is a nerd side of my personality which likes to be very exact and very accurate. And so when someone says depression, I feel depressed today. You know, I'm depressed today. What I think is, well, depression is a diagnosis. It has, you know, there are several diagnoses within that group of mood disorders, which include, you know, features of what we would all call depression. But, you know, my brain kind of goes technical. It's like, oh, well, that's a diagnosis. And I think what people mean is, well, I'm feeling more sad today than normal. My mood is more low or down than normal, or more than I'm comfortable with. But depression, in my brain, you know, has 7 or 8 criteria, and if you meet 3 or 4 of those, then you get a certain diagnosis. I think it's good, though, that the word depression is in, what's the word, regular culture. It's a good kind of adaptation or co-optation. A not good kind is, sometimes people will say, oh, I'm being crazy today, or, oh, I had a great weekend. I was OCD all weekend and I got my house cleaned. Well, you probably weren't really being OCD, as the diagnosis would go. What you mean is you had a lot of energy, you focused on details, maybe you were a little compulsive or over-focused on certain things, but that's totally different from the diagnosis of OCD. And so, again, I think it's good that people that aren't professionals are kind of aware of diagnoses and are aware of different features of those things, as opposed to, adopting non-person first language, where a person says, well, I'm being psycho today, or I'm really crazy, or that guy is schizophrenic, and saying it in a not nice way. That's not a good way of mental health terms being in the community.
Can I add something about depression? One thing I would say is that in my mind, when you talk about it as an actual condition as opposed to a feeling that you might have one day, I would say that it's characterized by persistent sadness that's really hard for one to come out of, and that it's distinguished from conditions like anxiety by specific symptoms like feelings of hopelessness and feelings of worthlessness, so that when someone actually has like a level of depression that meets thresholds, their well-being is significantly compromised in terms of just the ability to function in life. And some people tend to have attitudes around depression like you can just snap out of it if you talk yourself out of it, and that's not really shown to be the case. There's chemical components to it in terms of brain chemistry and serotonin and whatnot, and so it's important, I think, to take those things into consideration as well.
Absolutely, I 100% agree, and I want to emphasize the word you used, functional component, right? If my mood is so low that I stay in bed and I don't go to work and I get fired, my depression, has functionally impaired me and caused negative consequences, as opposed to, well, I'm feeling kind of depressed today, I might cancel on a friend and not go to a concert that I was planning on going to. Well, if that's an isolated event, it's not a big deal. But when the symptoms begin impairing your function in your social, occupational, and other roles, that's when we're talking about depression.
And depression for me was very functional. We lost a 5-year-old daughter. Very unexpectedly, we had to make the decision to put her in hospice and to basically pull the plugs on her. I didn't allow myself time to grieve. I had things to do, children to take care of. I walked around in a fog with my feet in cement for 15 years. Never allowed myself time to grieve. One foot in front of the other. I'm what they call a stuffer. I can't deal with it. I don't know how to deal with it. We're stuffing it down. Well, how you doing, Karen? Hey, I'm great. Everything's good. And the whole time, I'm lying. I'm lying to you, and more importantly, I was lying to myself and didn't even realize it. That fog was overwhelming, but yet I still managed to function.
That's an interesting perspective when we talk about functional versus not functional, right? If you're stuffing it down, are you functioning? And what did that look like for you, Karen, when you decided like I'm not functioning in this space?
It's when I actually was given the gift again of functioning that I realized how piss poor I was functioning before. It was to the point for me to function at what I thought was a good level was to isolate myself from everyone. It was much easier to stay at home, shut off the phone, break all my connections with my friends, so I had less people to fool. So I could just fool my kids. It's when, because we adopted special needs kids, that it came time to register them for school. And I started meeting other moms that had kids with special needs. And they started to talk to me, and I found myself answering them back. That was a slow process. It was a painful process. But I realized how isolated I had been and how very depressed I was. So building those connections is kind of, I hate to use the word, a light bulb went off, but it brought enough light into my life that I realized how dark it had been, if that makes sense.
It absolutely does. Yeah. Thank you for sharing your story. And kind of going into that, what does anxiety look like? How does that manifest? Because often depression and anxiety go hand in hand and become as one almost, not as a separate diagnosis. So can you tell me more about what that looks like, whether it's something you've experienced yourself in both worlds or in the clinical sense?
Okay, I'll start and then I'll hand it over. So I would say, I think it's true that depression and anxiety have a lot in common, like they have some symptom overlaps and they both respond to some of the same treatments and whatnot, but they are different. Anxiety is more characterized by excessive worry that one can't control, and it tends to be kind of out of proportion to what's going on. It tends sometimes to be pretty generalized. Symptom-wise, high states of agitation, restlessness, irritability, inability to slow one's thoughts down. And one piece with anxiety that I think is really important as well is that it's very much in the nervous system, if that makes sense. People kind of go into constant fight-flight mode. And if you know much about the nervous system, we're either calm or we're in fight-flight mode. And with anxiety, you often get people who are just constantly activated and not very well able to take themselves out of that state.
And see, I don't think I suffered from any anxiety, because for me that would have been an emotion. And that it is an emotion that I probably couldn't have dealt with. So there again, I would have stuffed it down, because I couldn't deal with emotions. I could deal with what was present and in front of me. But to have to feel or cry or even have a belly laugh was completely foreign to me, completely foreign. I lost touch with it.
I would add that, yes, there is a lot of overlap. And in fact, I think that as professionals, we used to think of depression and anxiety as two different things, whereas now the model is more like two sides of the same coin. Sometimes the best treatment for anxiety is a high dose of certain antidepressants, and that's neurochemically because some of the same brain receptors are involved. But typically people think of depression as what we would call the vegetative symptoms, being a couch potato, right? You want to sleep too much, you don't have any energy, you're apathetic, you may eat too much or you may not be hungry, you may have trouble sleeping or you may overeat. Whereas anxiety, I think people mostly think of as like on a spectrum. A low-level anxiety would be just kind of anxious, maybe a little jittery, all the way up to panic.
This is a question for Shannon. In what ways does trauma play a role in developing anxiety and depression?
So I would say that trauma can feed into depression and anxiety at any point in the life course. But one of the things that I think is most important to think about is that childhood trauma in particular can kind of situate or set people up for having struggles like that. I would say for a variety of reasons. Trauma affects brain development. It also if the trauma during childhood is relational, can change the way that we attach to others so that it creates relational difficulties. Beyond that piece, also in terms of self-regulation, like during childhood, we learn how to self-regulate through secure relationships. And so when there's childhood trauma, sometimes that can be compromised. Basically, I would say that all of those things just kind of create a baseline for functioning that can make it more difficult for people.
Karen, one of your adopted children tragically passed away due to complications from microcephaly, a result of the biomom's drug use. Could you share your personal experiences navigating depression when mourning the loss of your child? And I know that you had touched on it a little bit, but could you give us a little bit more story about that?
A lot of what I felt was guilt. I felt like I had handed this child a death sentence. And I didn't know how to deal with that. Because ultimately, this is a child that was 5 years old that couldn't say a word, but she could speak volumes. And her doctors told us there was nothing more that they could do. So we had to make the decision to end this child's life so that she didn't have to suffer anymore. And that's a heavy guilt to have to bear. It's hard enough as adults when we're given a diagnosis of cancer and you have 6 months to live. You can have an adult conversation and say, these are my wishes. This child never had that opportunity. That is not a discussion we had with a special needs child. That guilt manifested itself months after, because we were still mourning. And to this day, I don't think I've ever actually released myself of that guilt. What I've done is I've given myself grace to acknowledge that. But that guilt is part of what was part of my depression. Guilt is a pretty heavy thing to bear, especially when it involves a life.
Often when we are in the throes of depression and anxiety, we isolate ourselves. And this is for all panelists, can you tell us more about how harmful isolating can be and what we can do to connect again?
I can just start off saying it was very detrimental. I was very lonely, and it was probably the worst time in my life to be lonely. I wouldn't recommend it to anyone here, so please don't do it. I lost where I was going with that. See, that's part of depression too, you know. Isolation is just, it was a coping mechanism for me because it was easier because I didn't have to answer questions. People say, how you doing? And then I'd have to lie, stuff it down. So it was just easier to avoid for me. So, yeah, that's how I dealt with it.
Is it fair to say that it was protective, and in some ways that was a good thing, but it also was protective in not a good way?
Absolutely, 100% to both. Yes, it was definitely self-protection, especially with the guilt, which is something, I mean, you can share the death of a child, but you can't share that guilt that you made the decision to pull the plug on a 5-year-old child. So yeah, it was easier to protect myself.
In my mind, there's a big distinction between real guilt and false guilt. If the speed limit is 30 and I'm going 60, I am guilty of speeding. If I shoot tiny, I am guilty of or whatever that legal charge would be. Hunting. Hunting tiny without a license. As opposed to, I shouldn't work so more. I feel like I should be a better dad. I feel guilty for not doing everything I could as a dad. Well, what have I really done or omitted? What have I not done? Sometimes we're guilty by omission, right? But I think there's a big difference in how we can process that in a healthy way of those two different kinds of guilt.
One thing I would add there also is just that when you look at depression, you can also think of it as a thought disorder as much as a mood disorder, where part of the reason that we experience is depression is because we have these thought patterns that are not exactly accurate. And so kind of going back to the guilt theme, our minds are really good at telling us things that aren't true and that make us feel very, very bad. And so I think that's a piece of it too. But going back to the isolation question, I would also say that it's very common in depression, but I would say even more common when depression is overlapping with something like traumatic grief. I work at UCCS, like in a university context, so part of what I do is research, and coincidentally, my research focuses on traumatic grief. And it's basically what happens when someone has a major loss, but that loss is traumatic. And so they're having both grief and trauma symptoms at the same time. And both sets of things make each other worse and just makes it much, much harder to move through. Guilt is a big piece of that. And as you had noted in terms of guilt being reflective of reality versus what our brain is giving us, two different things, which makes the depression worse.
I remember when I was a kid and was struggling with anxiety and didn't know it. And I spent a lot of time with my stomach hurting all the time, just hurting. And I didn't understand why. And it was always around the school day. And it wasn't until really my mid-20s that I realized that it was anxiety. And I lost a lot of weight in college and didn't know why and all the things. And medication changed my life, I think. But until I realized what it was, and I did want to bring light to that too, of what symptoms of that could look like in youth and in children that you may not realize are symptoms of anxiety or depression. For example, if you see a child who spends a lot of time in the nurse's office with a stomach ache, it could be anxiety. Or even asthma is another. If they've experienced trauma, asthma is often a byproduct of that. So there's connections and there are warning signs and things that we can look out for. But realizing that in ourselves too could make all the difference with anxiety. I just worried constantly. And the medication, I think, did a really good job of masking the symptoms, the physical symptoms, but there are times where I still have the thoughts. They're just not paired with, I can deal with them better because I'm not ill.
And I'll say one thing about medication, which is I hear from people a lot, I don't want to be dependent on medication. Well, I like to think of antidepressants as, helping people at least to be on a level playing ground that, antidepressants are going to take away all of the adult problems in the world, or you still have bills to pay, you still have, whatever your life issues are, but at least it gives you the opportunity to not be in that figurative pit to where you can cope with emotional things and you can think more clearly. I mean, your depression has to be pretty advanced for you to have cognitive deficits to where you're having memory loss and other things like that. But even, non-severe depression can kind of take that edge off to where it's just difficult to cope with your regular life.
Medication is a lifesaver. I put things, I wouldn't say in perspective because I had to do that, but it gave me the ability to see more clearly. The fog was lifted. And when that fog was lifted, I was able to see, and then I was able to seek. And in that seeking, I found my tribe. I found a little bit of myself again. We're still learning where she's at. But whoever invented the medication I'm on, they deserve my kudos because I just love them.
So if you feel comfortable, raise your hand. Have you ever been in a community that was anti-medication? It might have been a religious community. It might have been an occupational community. Yeah. I'm not surprised. There are certain biases. And one of the things that goes against medication is the false idea that, well, natural things are better for you and pharmaceuticals are not natural. Well, there are lots of things that are natural, but that doesn't mean that, air is natural, but it's not going to cure your cancer. It's not going to cure your depression. There are neurotransmitters, neurochemicals in your brain, and when those get depleted, you need medication. Medication is very helpful in getting that corrected. For a while, there was a big push for people taking St. John's wort to treat depression, which is a great idea, except for the fact that it doesn't work. That would be awesome if it did, but clinical studies did not show that it helped treat people's depression. And so, evidence-based is what we recommend.
And medication supplementing with connecting with community, with your tribe, and with therapy is, and it's different for everybody, right? It's different for everyone. And that's kind of what I wanted to get into too, is the struggle that most of us have with accessing care that is affordable. I've had to recently make the decision to only see my psychiatrist because I need my medications. But I can't afford to do that and see a therapist because it's $150 an hour or something. For my psychiatrist, it's $150 for 15 minutes. So it's almost, you have to pick the lesser of of two, and having to make those decisions is something that a lot of us do every day. Do you have any advice on how to navigate the behavioral health system when you have to make those kinds of decisions?
Yeah, so my mind goes to kind of macro level change kind of right away, just because the reality is that we need a system that doesn't make it so darn hard. So advocating for more mental health funding for systems that just make things more accessible. But within the context of the system that we have, looking for offices that have sliding fee scales, up in an area like Woodland Park where we're kind of more remote, or you would have to go down to Colorado Springs for that kind of thing. There is telehealth. A lot of people hesitate to make that jump because they would prefer to be face-to-face with someone. But telehealth can be helpful, and I think that's kind of another avenue to possibly explore. If you can find a place that has telehealth on a sliding fee scale, it can increase accessibility a little bit.
Thank you. The system is messed up, guys. And that's what I'm here. We're all in this room to learn more about how we can make it better and more accessible for folks, because this is really important. And often people are making the decision, do I put food on the table or take care of my mental health, which is a terrible decision to have to make. And so we're working on it. But thank you. I was just curious what your thoughts were. And there's no surprise that there's silence in that, right? Because it's such a big, it feels too big to be able to do anything about. But I think within our circles and our connection points, connection is key. And relying on each other and our neighbors and our people.
And I just make the copay on my medication, so I'm very fortunate for that. And it's very affordable, so yeah.
Until you need to get it refilled and you need a new prescription. And then,
Then
it's
you
like,
have to go see the doctor.
And then you have to go
it's
see a doctor.
The mortgage payments. Yeah.
Yes.
Yeah, as a grad student, I did an internship in Texas in a center where we did on sliding scale counseling for the community. Does UCCS offer that to the community or to students or neither?
To the students, I'm not aware of community services through UCCS for mental health, but we have a student health center.
Right, yeah. Sometimes universities will do that.
That's another resource. And it's just about knowledge of resources that we do actually have a lot of resources up here. You may just not know about them, and we'll talk later about how you can access those resources in our community. What are the dangers of labeling? So I know, Alan, you had talked about you overusing almost the words anxiety and depression aside from it being a diagnosis. What are the dangers of labeling anxiety and depression if that's not something that you are diagnosed with?
Well, I guess my favorite example is bipolar disorder, which has to do with a mood that's too elevated and a mood that's too low, is one of the hardest, most difficult diagnoses to get right. So it's often overdiagnosed and it's often underdiagnosed. And people think of it as, oh, my moods are just all over the place. I'm bipolar. And so as a private practice therapist, I have many times been in counseling sessions where one spouse will want to accuse the other of being bipolar. And my point is, mood dysregulation is not bipolar disorder. Now, bipolar disorder does have that feature. Sometimes people have a decreased need for sleep and an elevated mood and risky behavior and impulsivity. But when people have trouble regulating their moods, that isn't a disorder. That's part of life. When children do it, we call it a temper tantrum. When adolescents do it, we call it hormones. When celebrities do it, we call it acting. So, just having your moods all over the place is part of life. But again, if it comes with a functional impairment and if it comes with the other symptoms of bipolar disorder, then then it may be appropriate for a person to, have that diagnosis, which essentially a diagnosis is just a label, right? It's a group of symptoms and we put this name on it and it's the label for that particular group of symptoms. And because there is overlap across different diagnoses, sometimes the cluster that you have fits one diagnosis and sometimes the cluster that you have fits another diagnosis. So it's important not to diagnose yourself. It's important not to diagnose your loved ones, even if you are a professional. But it is important to be a good listener, to be supportive, and to tell people, I'm really concerned. You used to never be late for work, and you've been late a lot lately. Is there something going on? Be attentive to changes in people's behaviors, thoughts, their appearance, their moods. Be aware of those things for the people in your community that you normally interact with, and be an advocate for them to say, this might be something that you want to talk to somebody else about.
And I'd like to touch on that. Don't give up. Just don't accept that, hey, she's okay, but she's not coming out. Or all of a sudden she's not going out for dinner. Don't take, I'm great, everything's good, as I'm closing the door and pushing you out it. That's not okay. Fight. Stay on them. Just like you said, communication, you're not okay. How can we help? Had I had someone push through that, I guess I'm a little bit tougher than I appear at times, that tough exterior, and say, no, Karen, you're not okay. What can we do? It may not have been 20 years of feeling like garbage, which I don't anymore, by the way.
Yay. Good.
What are some myths about anxiety and depression that you hear that you'd like to?
I'm sorry, somewhat?
Myths.
Myths?
Myths about anxiety and depression that we can.
You don't run around in a house coat all day and eat bonbons and lay around and watch TV. Appearances are deceiving.
I would say one of my least favorite would be the idea that it's a choice and that you can choose your way out of it. A lot of people kind of talk about depression and anxiety being akin to something like cancer, right? Where that's kind of a very strong comparison, but the point in making the comparison is essentially that it's an illness that you don't have a choice or control over in the same way as physical illnesses. And so the idea that if someone tells you that they're struggling with depression and you tell them, but your life is good, that's not helpful, you know? And so recognizing it for what it is in terms of something that somebody, it's a legitimate struggle. So.
Thank you. If someone in this room is struggling with anxiety or depression, what would you tell them?
Seek help. It's there, it's obtainable, and you get to see the sunshine again. That's a pretty cool thing.
Yeah, and I guess what I would say is to resist the negative attitudes that we have in society about mental health stuff. People often feel like if they're experiencing it, they can't acknowledge it, say it out loud. They have to pretend like it's not the case. Bunch of drunk. So, I don't know. Like, I think more people than not experience some kind of mental health issue over the course of their lives, whether they acknowledge it or not. And to sit in isolation with it and to feel ashamed by it and to not seek help or be honest about it because you're worried about what other people might think. That just worsens isolation, worsens the symptoms, keeps you from being able to move forward, and everybody deserves to be seen and accepted and able to move forward.
I would probably say a lot of things. The first thing that comes to mind is hope is a thing. Right? There are lots of good reasons to be hopeful. You may not feel hopeful. That's probably part of being depressed. But there are good therapies in terms of talk therapy, medicine therapy, exercise therapy, art therapy, et cetera, support groups. So there is a lot of hope. There are a lot of ways to get help. I would also say, don't kid yourself that it's just going to naturally get better, because tragically it might get worse. I mean, very serious cases of depression can lead to diminished mental capacity, and that is an extreme, but it does happen. It can also lead to suicidal thoughts if they're not already there. Your depression can get worse to where previously you hadn't had a thought of suicide. But without treatment, things can get worse, and it's always easier to intervene. Sorry, easier is the wrong word. It's better to intervene earlier when the situation is smaller rather than later when the problem or the situation or condition has a lot more momentum and is bigger.
Well, I have some questions from the audience. I need a desk up here. Desk. A printer. The first one is, how do you help someone who hasn't truly grieved a significant loss because they're always in caretaker mode and you know that they need help? I'm looking at you, Karen. I'm just curious if you How do we help someone who hasn't truly grieved a significant loss, help them through that?
Well, I am probably not the very best person to ask that question to, seeing as I didn't do it very well. I would say give yourself the grace and the mercy in a dish towel in a quiet room and allow yourself that time to cry. I think crying is a natural healer for some people. I can't speak for everyone. Because I was so busy taking care of people that I just did it. I don't have a very clear-cut answer. I would suggest maybe a support group that specializes in grieving. Talking to your best friend, having a glass of wine with your best friend if that's what it takes to loosen up a little bit. Do not become an alcoholic on my account, please. Talking to a professional. If I had taken those steps, I probably could have avoided a lot. But grieving is not a instant turn it on. It took me years to get to the point to actually grieve my daughter's loss because I was in that fix-it mode for everybody. Just get the dinner on the table. Make sure everyone has clean underwear. Get the kids to school on time. Grieving it's a process, and it's a lifelong process. So my advice is seek professional help. I don't have an answer for you. I'm sorry.
No, you did have an answer, and that was based on your personal experiences. And I think when we're trying to support somebody we really love and care about in their grief, we don't know how to do that. And it's tough to know what to do when somebody is breaking down in front of you, and you want to fix it, but there's nothing you can do to fix it.
No, and it's such a personal walk.
So listening, right? And being there,
Listening.
and even just having presence, sitting in silence with them, even if they're not ready to seek help at that moment, maybe just sitting with them, would that have been helpful for you?
It would have, yeah. And a good chick flick maybe to bring the tears on might have helped. But yeah.
And one thing I might add also is just kind of calling the pattern to their attention gently. So as I mentioned, I do a lot of research on traumatic grief, and what you're talking about, or I guess what the question is talking about, is very common. Like in the aftermath of loss by death, for instance, people will go into just do mode. And grief doesn't happen because they're taking care of others and they're taking care of things. And then the walls come crashing down at weird moments years later when that's no longer the case. And so calling to the attention of the person that, maybe they're blocking their grief process in this way. Maybe trying to pick up some of their responsibilities so that they have space to attend a support group, or so that after the support group they can come home and cry instead of making dinner, Yeah.
Yeah, I didn't open my daughter's bedroom door for 2 years. I was sharing with Ashley, I cannot handle the smell of Johnson's baby lotion. That, to me, was the essence of my daughter's smell, was Johnson's baby lotion. Can't handle it. So I think maybe a little PTSD crosses over in with grief. I'm not sure on the clinical side of that stuff. I'm winging it, making it up, trying to look real smart up here with these guys. But yeah, so grief has many tentacles. There is no one answer for it. Not one pill for that.
I would say to the person that grief is not a mental illness. It's a process that people go through after a loss. I like word pictures and analogies, so I would remind them that, sometimes We have to put our own masks on if you're on an airplane and the mask drops down before we help others. And so I would also, again, point out what I see in that person and why I'm concerned. You know, just like charging into the room and saying, Dad, you're an alcoholic and you need to stop drinking. That is not likely to be effective. Neither is saying, you know, your grief is killing you, you need to get help. But if they see your genuine concern, if they see that you're really reaching out and trying to connect with them, that will likely be a softer startup to encourage them to either open up to you or decide that they do want to open up to somebody else.
Next question. How do you feel about transcranial magnetic stimulation treatment for depression? TMS. How do you feel about that?
Really not my area of expertise.
Yeah, likewise. I've heard people who do it cite studies that it is helpful, and so I kind of take their word for it that for some people it is effective.
No knowledge.
Is it the treatment where they stimulate certain parts of the brain that are being affected by depression or anxiety if there's somebody in the audience, okay, I'm going to bring the mic to you, who could talk about it a little bit more, because there's a science to it, and I have heard that it's very effective.
It's different than shock treatment. It's not shock treatment, where they use an electrical shock to stimulate the brain. So they do some measurements to determine certain areas of the brain, and there's a magnetic stimulation that goes between those areas. And the treatment is usually starts off with 3 or 4 days a week you have to do it, so it's kind of inconvenient. I know a psychiatrist who does it, and he specializes in treating difficult to treat depression, and you can treat other things with it as well. And the numbers, the statistics are good, that it says it's effective. I've had a few patients and friends who have used it, and it wasn't that effective. So it's hard for me to say that it's not effective, but I haven't seen it. But the number of people I've seen is tiny. It's worth talking to. Usually people who do that will spend some time talking with you about it. And it's covered by insurance now.
It's covered by insurance now. Did you guys hear that?
I wanted to speak to affordable psychotherapy too. And the other thing that everybody should do is ask for a discount. And I give people a discount, and they say, but you're worth so much more. And I say, if you paid what I was worth, nobody could afford it. So ask for a discount. Yeah.
Okay. And maybe if you don't feel comfortable asking for a discount, have like a wallet card that says, do you have a discount? And then you don't have to say it out loud. Thank you. Thank you so much for that.
What about the physiology of laughter?
The physiology of laughter. There's laughter yoga, is that what you're speaking to? Or just the belly laughs? There's some healing in that.
There absolutely is. And it's a release. It feels incredible, especially after you've held it in for so long and you do the little. I'm quite sure mentally, physically, in the brain part there is. I don't know that part. I just know the first time that I had a belly laugh, was over the stupidest things with some friends. And I felt like a high school kid for 15 seconds, and it felt incredible. And it was like this endorphin started kicking off in my head. And it was like, wow, I like this feeling. going to work on this a little bit more. So it was a process. It was a slow process, but now Ashley will tell you I laugh at everything, so yeah.
Thank you, Karen. And it is time for audience questions in addition to the ones I got on the phone. So are there any other questions? Yeah.
I was just curious if any of you know how many companies provide this kind of insurance, or if the companies do provide that kind of insurance, mental health insurance, do they make sure their employees know about it? And I bet the doctor would know a little bit about this. We were fortunate to work in a company that does provide mental health insurance, and we're able to utilize that for kids and what have you. And I know a lady that worked for a big insurance company who was a family health a family therapist, but she grew in that business as somebody who sold mental health insurance to companies, and was very successful at talking them into it, that she was able to, really convince them that it was very well worth their efforts and money to have that benefit available.
I apologize. I didn't hear a question in that.
So it sounds like the question is,
Well, I just wanted to know if currently very many companies offer that anymore. Mental health insurance. It's totally separate from the regular medical, and oftentimes you have to dig deep to find it, which we did, and it's there, but it's a total separate process you have to go through to access it.
Well, there has been legislation which is called mental health parity, and it has to do with if a company is going to offer insurance, then they have to include mental health just like physical medical help. It's a much bigger issue and a much bigger problem, though, in terms of company size and who's required to offer insurance and all of that. That's above my pay grade. I don't really have a comment on that.
As far as I know, it's still Colorado state law that you have to offer it, and it has to be, there has to be parity. Now, there's all kinds of ways around it. Usually, you have to be a provider for that insurance company and have a contract with the insurance company for the insurance company to pay for it. So you can't get it with out-of-network as an out-of-network policy. And then they work with how you define things. They'll say, no, the appropriate length of treatment is 10 sessions. So we cover 10 sessions. And the therapist may say, no, this is a chronic lifelong condition. Sorry. And you have to go through a review process. So insurance companies are in the business to make money. They're not in the business to provide health care. So you just have to know that going into it.
Oh, we could have a whole symposium on that.
I've been doing this too long.
Insurance. Right, okay, yes. Any other questions? We have time for one more. I'm coming. I'm not running.
So I have a 41-year-old who I don't want to say is bipolar, but pretty darn sure. But a widow 2 times over by 37. One husband was suicide and one was killed by a diesel truck on a Harley. And she's stuck in trauma bond and very toxic to our family. But it breaks my heart as a mother, understanding and seeing I don't know how to offer her help anymore. Everybody's cut her off. And she just continues to spiral. So what would you recommend to get someone like that help. I'm pretty sure she's bipolar and trauma bonded and still grieving the loss within the last 3 years of losing 2 husbands by 37.
Where do we start if we're supporting somebody with complex issues and get them help? I mean, if you're the connection, what I'm hearing is if you're their connection and it seems so big, like the problem just seems so big and you want to fix it, right? How do you connect them, or where do you start with somebody in that space?
My initial thought is that with trauma of that magnitude, trauma-specific therapy is pretty necessary. And if the person's not willing to engage it, that's a whole another issue in terms of how you inspire them to do so. But one thought I would put forward here is that not all therapy is created equal, and that in kind of finding something appropriate for that person, you would want a clinician who does trauma-specific work, who can do things like EMDR and trauma processing therapies and so on and so forth, because those are experiences that aren't going to be resolved through just talk therapy, for instance.
Are they open to sharing with you or with someone else? Like, are they isolating themselves? I heard you say they might be isolating. Okay. Okay. So also alcohol use too. So there's the mental health, the grieving, and the substance use, and the life circumstances, all of it is kind of combining into one.
And I would say, I mean, if you truly believe that bipolar is a piece of things, psychiatry would be important as well, because it's very difficult to navigate life with untreated bipolar.
And she had also mentioned that their support system is tired. And so what advice do you have for the support system? I heard Karen say don't give up and all of those things, and also where do we set those boundaries and continue to support somebody who is struggling and taking everything from, your resources?
My first thought is NAMI, the National Alliance for Mental Illness. I don't know if y'all have talked about that yet today, but it's a wonderful nationwide organization, and there is a chapter in the Springs to support people who love and try to care for and want to support people with mental illness. They have all kinds of support groups and educational information, and they can be a great support.
Yeah, and I would say that that's largely for the family members who are tired, and in addition, for the person themselves. Sometimes they might need to find support from outside of their original support network, given the effects on the original support network. And there are a lot of community support, like grief support groups to look into, if that person would be willing to connect to new people, if that makes sense. And support groups are incredibly helpful with grief. Yeah.
And there is more training available. Our agency is not the only one that does this. There are several agencies in the area, but there is a 1-hour class called QPR, Question, Persuade, Refer, and it's specifically about how to have that difficult talk with somebody that you're concerned about who might be suicidal. And it talks all about risk factors and protective factors and what the signs are and things to look for and how to approach that person, how to have that talk. It's a great 1-hour class. We also teach adult mental health first aid. It's a much longer class. It's most of a day, and we teach it in a couple different formats, either in person or online, and sometimes participants do 2 hours of learning at home on their own, and then the rest is in class, either virtually or in person, and that's about another 7.5 hours. But it covers the whole spectrum of mental health, substance abuse, suicide, all kinds of different areas related to that. And then it's a really good training for how you can help people that you know. I did print out some sign-in sheets, and I will, Ashley and I will figure out where to put those to make it easy for you to sign up if you would like to, but just give us your email and we will let you know when the next classes are. Oh, okay. So right now they're in my briefcase, but I will leave them here on the front row with some pens. So just give us your name and your phone number, and we will let you know how to connect for either or both of those classes.
Thank you, panelists, for coming today. Round of applause for them. You can leave your microphones on your chairs, and we're going to transition to our last panel of the day on reducing isolation and increasing connectedness. So we're going to give it 5 minutes. We have time for this, so it's okay. And so just please come back in 5 minutes. Thank you. I need to find my phone.
I run peer support for CDOT, and I have this employee who has gone through just a horribly traumatic loss, and kept trying to find, to his credit, kept trying to find therapists and grief groups, and it was just like, his loss was so heavy and traumatic that he was literally told, this is too much. Like the therapist told him, this is too much for me. And he was like, I really want to keep trying. I know. But you know, to his credit, he was like, I really want to keep trying. He's like, I just don't want to burden anybody at this point. And so I reached out to Kathy for some groups that, you know, I could recommend to him. And I got him some therapists, but she's just such a wonderful lady.
Yeah, I had someone else just last week, a couple months ago, reach out and say, you know, I've heard from one person. She was the whole big deal. Yeah, she was at not quite a year ago. It was about 14 months. And she said, I had this situation now, and his behavior's changed. She's quit talking. She said, you know, the home is
Hi, Ashley. Oh, ah. To get home, too. I mean, hi, wonderful. I'm Kelly.
Shelly.
Hi, Shelly. I'm Kelly.
Sorry, I have my security.
I guess. I have the security copy.
We're going to get started in about 1 minute for the next panel.
I'm so concerned that I'm going to get one.
Oh, no, don't trust me. It's just
I know, but that's my concern, is that my mind is in the way.
You got your estimate.
You know, I've never had a problem
almost, at least I think. Yeah. Well, and what is most likely to happen is that but you know, there's no security. No, it's there. It's there for you. Yeah, I was worried actually that it was gonna be like rainy, but it was like.
It's supposed to snow.
Yeah. It's surprising.
So we're good.
We're good.
Apparently it's beautiful outside.
Oh.
We just haven't been out.
Yeah. I got married in Woodland Park 8 years ago now.
At the golf course?
It was a bed and breakfast. Now I'm blanking on the name of it. It's like kind of close to the Roosevelt. Gorgeous. But it was May 27th, so I was like, we're far enough out of spring. But it rained, it snowed, it was foggy. And then as I was walking, so it snowed as I walked down the aisle, and then it was gorgeous. But I got all of it. I know. It's so funny here. Oh, how funny. It's crazy. Yeah, it's that just, one day stuff happens.
All right, we're going to get started as everybody starts to trickle back in. And we're here to talk about how connection can combat loneliness and isolation. And it's funny because I think I'm going to call you out because it's funny. When I approached Shelley about this opportunity, she thought it was combat loneliness and isolation. And she says, I'm not a veteran and I don't have experience in this. So it is actually the verb, not the adjective. Just wanted to make that clear and have a laugh. Yes. Anyone, anywhere can be lonely or socially isolated at any time. Across all ages and regions, loneliness and social isolation have serious impacts on our physical and mental health and the well-being of our community. The lack of social connection poses a significant risk for individual health and longevity. According to the U.S. Surgeon General, loneliness and social isolation increases the risk for premature death by 26%. More broadly, lacking social connection can increase the risk for premature death as much as smoking up to 15 cigarettes a day. In addition, poor or insufficient social connection is associated with increased risk of disease, including a 29% increased risk of heart disease. People are social creatures by nature, even us introverts in the room. Our relationships with family, friends, coworkers, and community members are important to our survival. Stable and supportive relationships give us the support we need to cope with stressful life challenges. Communities that offer supportive connections are just as important. They can help create trust and resilience among community members in public places. And the panelists here today are going to share with us how important connection is to combating loneliness. So I'm going to introduce them really quick. Nicole Weiss is the Director of Community Training and Empowerment at the Lyda Hill Institute for Human Resilience. Nicole is a 2016 graduate of the University of Colorado at Colorado Springs, master's in clinical psychology program with an emphasis in trauma. She is a licensed professional counselor, licensed addiction counselor, and registered yoga teacher. She's going to be teaching yoga today in front of you all and everybody in her heels. In her role at the Lyda Hill Institute, Nicole provides peer support training to several organizations in Colorado. She teaches the trauma training for professionals online program, manages the GRIT coaching program, and liaisons with the 4th Judicial Veterans Trauma Court. Welcome, Nicole. All the things. We have Kelly Hunsaker, thank you, I'm sorry, has been a long-standing member of our community for the past 22 years. For 21 of those years, she has navigated life on disability without a driver's license, which often made it difficult for her to connect with others. And before that, she was a lawyer, and so there's a firecracker in there for sure. Kelly's love for being around people inspired her to find creative ways to stay connected and engage with the community. She's also a devoted mother to 2 adult children. One of her sons, who is transgender, came out while in high school, which brought new layers of complexity to her family's life. Her immediate response was one of conditional love, unconditional love. I love you no matter what. Kelly's journey reflects her commitment to embracing and supporting the people that she cares about, no matter the challenges. Thanks for being here, Kelly. And next we have Shelley Lassiter-Reed, who is a licensed professional counselor at Good Grief Counseling and the community liaison for Voices of Grief. Shelley has been in the community for almost 20 years, worked in the Woodland Park School District for 18 years, and is recently retired from the school district to open her own practice. So welcome, Shelley. Thank you. As always, if you have a question throughout the panel discussion today, please text the number that will be appearing on the screen in front of you. And the questions that I'm asking today aren't in any particular order. It's discussion based, so feel free to have conversations around these questions. So I'm going to ask all of you, studies show that loneliness and social isolation, okay, my brain reset. Studies show that loneliness and social isolation are associated with higher risks of health problems such as heart disease, depression, and cognitive decline. Can you expand on this? And if you have personal experience, can you talk about your health issues associated with that, with social isolation?
I'll start. So I'm actually going to bounce off of what you said during the intro, which is that we are social creatures, even the introverts in the room. And there's research that proves that over and over and over again. We have what's called mirror neurons in our brain, which is the monkey see, monkey do neuron. And we never lose that, right? It's when you hold a baby and you smile and they smile. We never lose that ability. And so when we are socially around others, especially people who feel positive to us, our mirror neurons are going to react with that. And we are literally going to start, mimicking each other to the point where we can actually match breaths with each other. It's fascinating, that power of social, togetherness. And I think one of the things, and I'm sure we'll talk about it, one of the fallbacks of a lot of mental health is this tendency to socially isolate, which can then really exacerbate a lot of those symptoms. And so being together, engaging in that social piece, even if it's just on one-on-one, even if it's just physically in the room, makes a biological difference in your body.
I wanted to mention that sometimes this is also the reverse. Being someone who deals with chronic disease, I can tell you that my disease will often affect my mental health and create a sense of isolation that maybe doesn't need to be there. And I need to remember that. I will have a tendency to it's kind of embarrassing to always have to ask people for rides. Even though it's been 20 years, I still struggle with it. But if I don't do that, I find myself more and more isolated, which feeds my disease, and I get more and more sick.
So there's that constant cycle that goes back, and you have to pull out of it in a way and really reach out in those spaces. Thank you. Let's see. Shelley, when we think of the word grief, oftentimes what comes to mind is death loss. There are many ways that we experience grief across the lifespan, and you often talk about the importance of connection when in grief. Can you expand on the other types of loss where we might experience grief and mourning and need that connection with others?
So yes, when you talk about grief and mourning, people do tend to go to the death loss. But I want to expand on loss because grief and mourning needs to happen after every kind of loss that we experience. And so a loss is there's divorce grief, there's job loss, retirement. When you're placed in a facility or come out of a facility, there's a diagnosis, accidents, violence. thinking of everything we've talked about today, consider losses that come along with substance use, the adverse childhood experiences, depression and anxiety. You're looking at, there's a level of a loss of relationships, loss of hopes and dreams, loss of a lifestyle, loss of identity. All of those types of losses need to, first of all, be acknowledged, and then they need to be grieved and mourned. And so when I speak of grief and mourning, grief is all of the things that we feel internally about a loss. And then when we are able to start expressing those feelings outwardly, that's the movement of mourning. And so to acknowledge those, I think a lot of it comes from unacknowledged grief, because we don't tend to think about the losses that come from all of those other across the lifetime situations that cause loss that we need to acknowledge and grieve.
Thank you for sharing. Did you want to add to that, Kelly?
Yeah, I would say that some of the things I've grieved the hardest haven't been the death of people. Sometimes you beat up on yourself, because even as I said that, my first thought was, oh, don't tell people you grieved that. But I grieved my ability to work outside of the home. I grieved that I had spent 10 years in college and no longer could practice law. I grieved how I defined myself, because everything about how I defined myself had to change when I got sick and was put at home.
I'd like to expand too, because I also think there's, and you can probably tell me too, if there's situations that it feels complicated because it might be something that you're grieving that you're also kind of happy about. And then you get this really complicated feeling of, well, why am I sad, right? And when I should be happy, or I'm happy, but I should be sad, right? We have these kind of expectations on ourselves. And the reality is there's some situation where it's both. You can be happy that something is ending and sad that it's gone now. But I think that adds to kind of the complexity of our human lives.
To take a step back, a question that I have here is, what is the difference between loneliness and social isolation?
I think loneliness is a feeling, and you can feel lonely in a room full of people, which is, I know the last panel talks a lot about depression, and that can definitely be true of depression. Social isolation tends to be more of an act of physically isolating, or, as we think about COVID, socially isolating in a lot of ways. And they can both exist at the same time, but they can also exist separately as well.
Thank you. How do experiences of stigma reinforce those feelings of loneliness?
I think that's a little bit what I was just saying. I think we put so much pressure on ourselves. I think stigma usually comes from our own internal emotional reaction to something going on. And so we put these pressures on ourselves. Like I said, the first thought that came to my head was, don't admit you grieved being a lawyer. Like, that's a stigma I'm placing on myself. I'm sure none of you were like, well, of course you know. So it's hard because we beat up ourselves easily. And sometimes we think we're the only ones doing it.
I think there's a part that when we are isolating, we really kind of ruminate or overthink negative thoughts, and we get stuck in those negative thoughts. We start to believe that other people are tired of us, that we cause other people to be depressed when they're around us, and so we draw further and further away because we ruminate on those negative thoughts, and so that increases that kind of stigma because we start to believe those things.
I think it also goes into that expectation of yourself as well, of the should and the should nots that you place on yourself, right? So if you're this tough guy who's sad, well, I shouldn't be sad, or I shouldn't admit this, or that whole, we're told, since we were itty bitty, big girls don't cry. We have these expectations on ourselves, and I think that really can build into the stigma of not seeking help because we expect something different of ourselves. Or the occupation that we're in, like lawyers, right? Lawyers, it might be really hard for them to admit, I'm in a difficult place right now, or I need help, or I can't perform the way I used to, right? I don't know if you want to speak more on that, but I think it really comes to that expectation.
Yeah, I definitely agree that certain jobs are more apt to close up and not share with one another, not discuss things with one another. I don't know many doctors personally, but I've heard they struggle, which I've always found interesting because they have the most information, But yeah, lawyers are definitely one. It's kind of a dog-eat-dog world in that way.
Are there some key events across life stages that are associated with periods of loneliness?
I would argue every stage of life has an aspect of loneliness to it, right? I have a 3-year-old, and she experiences loneliness, right? It's down from the little kids, and then, you go into school and you're transitioning away from friends. There's loneliness that might come with that. I think any transition period can come with an aspect of loneliness.
Do any of you have any personal experiences with a life transition and loneliness that came with that?
So most recently, I retired from education after 25 years. And so I retired from that in June. And it was a very exciting time because I was starting my practice for good grief. And so there was a lot to look forward to. And what I found was in August, I suddenly didn't have, 30 other people around me going and having discussions and getting ready. And here I am now just all by myself. And, talking about grieving those stages of retirement, the first day of school, that's the first time in 25 years I didn't go to the first day of school. And so I'm doing, like what you were saying, these two things. I'm happy and excited, but also who am I? Because I've been this for 25 years. And so, it can happen, all of the transitions, all of our life changes come with there's a period of that grief and mourning, and acknowledging that is where then you recognize there's a loneliness here, but that doesn't have to turn into then that isolating, because being lonely isn't necessarily a bad thing, unless it, dips down into that full withdrawal. But yeah, that's my most recent. I can think of that. Yeah.
When my dad, the last few years of his life, he had Alzheimer's, and that was a constant transition. There were constant losses. Every couple of weeks, it felt like there was another loss. There was something he couldn't remember. There was something he could no longer do. There was an emotional reaction that changed. He would get lost in his own building. And that was really difficult for me, watching my dad fade away. I think that's one of the most intense periods of loneliness of my life. And it was actually much more a time of grief even than after his death was.
How did you come out of that? It sounds like connection with the community. Could you expand on that?
Yeah, after he passed and I got through the immediate aftermath of his loss, I found myself back at home, stuck at home while my husband was working full time, and it really was one of the first times that it struck me how alone I always was. And So I intentionally started looking for groups in the community that I might be able to be a part of. And to do that was difficult since I don't drive. So I had to find groups that other people I loved were also interested in so I could catch rides, you know. But I made a real intentional effort to get involved. And it was really good for me. And I didn't know how good for me it was until a few months passed. And I felt like I was coming back into myself.
When you and I were talking, just to further expand a little bit, you said there was one interaction that you had with someone that really brought you to yourself and what you were struggling with. Can you tell us about that? With Allison.
Yeah, so it was just this winter, last winter, January, February timeframe, and I was kind of sinking into depression. My life had slowed down drastically from last year. Last year I was really busy with some activities, and my life had slowed down, and it hit me really hard, but I actually didn't recognize it until my friend came over one day just to visit. We were sitting visiting, and after we talked a little bit, she said, "Kelly, I really think you're depressed." And it was the most wonderful thing for someone to do, because I think I would have gotten much deeper into that depression before I recognized it myself. But she said, "You need to start getting out again." And so I said to her, "Okay, please ask me, you know, and if I say no, ask me a second time, because I might say no." And so she did that, and within just a very short time, I was healing.
Thank you. And to add on to that, a question for all of you is, we have a tendency to answer fine when someone asks us how we're doing. What is the importance of being vulnerable in that time with someone you trust and sharing how you are actually doing when asked that question?
So earlier today, the comment was made about sharing your story with people who have earned that right. And I would say that when someone asks you how you're doing, there's a part of you that knows who you need to, that's all they want to hear. They want to hear, "I'm fine." And so that's your answer. But there are people who you know, when they ask you, "How are you doing?" they want the more, the deeper. And so you know those people, and if you don't have those people, you need to find those people, whether that's a friend or a group or counseling. You need to find that person that you can be vulnerable with, because we need people in our life that we can say more than, "I'm fine." Yeah, but there are going to be the people where that's just the answer.
You're right. And we kind of sense that, right? When somebody is asking that question and they may not really want to know. But I know now, like I saw my mom last week and I said I was fine. And she gave me the mom look of like, "I don't believe you. You need to tell me more." And I ended up telling her more, but she knows me and I trust her, and it's a safe space for me to share in that space. But usually it's almost like a nervous tick where I'm just like, "Fine, I'm fine."
I think it's also our culture, right? That we have, in our very Western world, we have a tendency to say, "How are you doing?" as a greeting, not as a true question, right? So how many times you think about, you come to church and you say like, "Hey, Ashley, how's it going?" And we're not really asking Ashley, "How's it going?" right? We're just greeting, saying, "Hello, good morning." So I think there's also a need for this kind of culture shift for us to slow down and say, "No, I'm asking, how are you doing?" And when the answer is fine, maybe following up, especially if you're in a position of trust, to say, "No, how are you really doing?" right? And allowing yourself the time and space to hear that answer. Because I think sometimes we're fearful of, well, if I do say, "How's Ashley doing?" and Ashley says, "I'm not good," well, now I have to figure that out, right? And so I think sometimes we can get a little scared off of asking the real "how are you actually doing" question. And as a therapist, in all the work I've done in my mental health field, 9 times out of 10, somebody just having the permission to say, "No, this is how I'm actually doing," that's where the magic is. You don't have to have the answer. You don't have to have the follow-up. It's more of just, "I'm willing to be in this space with you."
And there's authenticity in that too, right? I truly, truly want to know how everyone is doing. And it's usually in a situation like today where there's a lot going on and I want to give you my full attention. So if you are fully intending and with authenticity to know and to learn how someone is doing, also making sure that you're in a space to stay there with them if they need to share something. I'm totally guilty of that, and I'm sorry to everybody in the room today if I walked away from you. I didn't mean to, but I think just being mindful of where you're at when you ask that question, and if you do really want to know the answer, and staying to listen. Everyone needs social connections to survive and to thrive. But as people age, they often find themselves spending more time alone, especially when transitioning out of the workforce, right? And a lot of the connections that you have had have been professional. If I find myself isolating, what small steps can I take to get connected?
I'll start. Find a friend that not just knows to ask you those questions like, are you okay, and actually listen to your answer, but we have a mutual friend who gives a hug that heals you and lasts for weeks. You carry it with you. And it's so important to have a friend like that. Someone who brings that kind of peace into you. And I went a lot of years without a friend like that. When I met this person, the very first day I met them, they gave me that kind of hug. And I was like, oh, I've been missing this. You know, it's so important to have that ability to reach out to someone, but also to have a person who will reach out to you if you're not doing it.
I think it's important to have an understanding that grief, mourning, isolating, all of those we need to take in doses. They need to be dosed. We cannot, our bodies can't physically carry that amount of grief and pain all the time. So we do it in doses. We don't tamp it down, right? We have to feel it when it comes up. We have to experience it. But in those have to come in doses, and then we have to, distract yourself. Give your brain and your body a break, and do that however you can. I do think it's important to start out small, and so I think it's important to get outside every day. And if all you can do is 10 minutes, do 10 minutes, and then build on that. But there needs to be movement. And then I would say there's a lot of talk right now about gratitude and talking about what you're grateful for every day. And I think there are times we're in certain spaces where we're not really seeing what there's anything to be grateful for. We're not full of gratitude in the moment. And so I would say to start thinking about, instead of naming 3 things that I'm grateful for today, maybe I can name 3 things that I was able to do today. I was able to get out of bed today. I was able to sit outside for 10 minutes today. I was able to walk to the kitchen today. Whatever those small things are. And starting small in the beginning is what just has to be done. If those 3 things are the only things I was able to accomplish today, then yay me. And then each day maybe I can accomplish a little bit more, but there's always got to be movement.
I don't know if anyone else needed that, but I needed that. Thank you.
I do a lot of training on stress and burnout. That's where my expertise is. And as a therapist, one of the things I like to call out is that we have dumb, smart brains. Our brains are very smart. We're capable of amazing, wonderful, accomplished things. And we also have dumb brains. And the fact that our brain will look for patterns. And when the pattern we give it is social isolation, right, then that's the pattern it looks for. And it reinforces everything that leads into social isolation because the brain is just doing what it's told to do. When we give it different patterns, like this is what I'm grateful for, or this is what I was able to accomplish today, or this is what was in my control today, even when they're little things, like I got out of bed, I drank water, I went for a walk around the house, the brain goes, oh, that's a pattern too. And so the brain starts to look for those things just as much, right? Then I have more things under my power. I have more things I'm grateful for. There's more things that make me happy. And I think the same is true with that combating social isolation, is what you said, start small. Maybe even be a little proactive, like I'm gonna call somebody, a friend that I haven't talked to in a while. But the more that happens, the more the brain goes, oh, that's a pattern. And I can reach out to more, and I can have more of that community around me. And I also think we kind of get into this tendency of waiting for the person to call us, or for the person to check in with us. I know my mom, for instance, she doesn't call her kids because she has the expectation that the kids will call her. But then it also sometimes means we're, a week from talking with her because, life happens. And so she's been waiting for us to call her. And so instead, to be a little proactive and say, well, then you call. If you're missing me, you call, right? But the pattern that's created her whole life is, no, I wait. And so again, I think it's just, I like to blame the dumb smart brain on a lot of things, but that's part of it, is we create patterns. And so if we introduce a new pattern, then things can look different.
I think I mentioned earlier that we get stuck in those negative thought patterns, and that's another one. When we're in our, I call it grief brain, when we're in our grief brain or our dumb smart brain, people offer us help and we don't believe them. Right. We think they're just being nice, or we forget that, these 10 people offered, we're not gonna make a list for them. We're not gonna, yeah, I need my toilet needs scrubbing. Would you go do that for me? We're not going to ask that. And we do tend to not believe when someone offers to be there for us. We tend to think they don't really mean that.
And I think that goes right back to stigma, right? And the expectations of, well, I should be able to scrub my own toilet, right? Well, the truth is, right, if you're sitting in that grief, then the toilet's the last thing on your mind, right? And so I think that kind of goes back to that expectation piece too.
You don't want to be a burden.
Yep.
It's one of those reasons I still struggle after all these years to ask for rides. It feels like you're a burden. To get over it.
And I don't remember who I was talking to. I believe it was you, Kelly, yesterday, where sometimes if we are constantly helping others, right, and we get something from that, but we don't let others help us, we're robbing them of that opportunity to help us, right? I think it was Karen. I don't remember. I'm sorry. But it really resonated with me because I do that so much where I'm like, no, I'm good. I'm fine. But I get so much, like it fills my heart to help others. So why would I rob somebody else of that joy to help me? And that mindset shift has really helped me to move forward and let people help me if I need it.
One of the things I talk with my clients a lot about is, do you talk to yourself the way you talk to a friend? And that's very similar to, right, are you acting to yourself the way you would act to a friend? Because, right, we're usually the first person to say, I will help you, I'll come scrub of course I'll scrub your toilet, right? Like, but we tend to be so much more negative and have these higher expectations on ourselves than we would place on somebody else.
I have a friend who told me once, because I had expressed to her that I was struggling to ask for the things I need, and she said, when someone asks you for something that they need, how do you feel? And I just said, well, I feel good. I like to help my friends. And she said, well, then if you don't allow your friends to do the same, you're denying them that emotion. And that was really helpful when she put it that way.
I also, and this is not quite your question, but I wonder if you and I can talk about it too, or all three of us can talk about it too. But I think sometimes when we're in grief, and again, in my world, it's kind of that trauma. We've just gone through something traumatic, something really stressful. We're grieving. Sometimes we don't even know what we need. And so when we are that person that's saying, I want to help, sometimes we ask, well, what could I do? How can I help? And the answer is, I don't know. And part of that is because the brain's already overloaded with what it's feeling, right? I'm feeling this grief, I'm feeling this trauma, whatever it might be. And so if you're the person that's like, well, I just want to help, just go do it anyway, right? Like, well, I just brought you lunch. I'm not, I can stay or I don't have to stay, but I just brought you lunch, or I just did this for you because you're on my mind, right? And I think there can be a lot more of that.
Yeah. I would say when you're the person that wants to help, that's what we do. We say, hey, I'm here for you. But then what we've got to do is we've got to be the one to follow up. we've got to recognize that they're not going to remember that we offered. They're not going to believe us that we truly want to help. They're overwhelmed, and so we've got to be the one to follow up. And with that, I know this was talked about earlier too, we want to be the person that's there to listen and hold space. And so it's important that we're careful about our advice giving. I would say be very careful about comparisons. That, oh, well, so-and-so, she's got it so much worse, so you're going to be just fine. That comparison, that cliched comments to the person who's in that grief situation, those comments come across as flippant and judgmental, and then they're going to turn that on themselves. Well, if she can get through it, why can't I? What's wrong with me that I can't? And so when we offer help, that we've got to just be there to listen and hold space with them, not try to fix it, not try to, and I do think, if you're the friend that you're in the house and you notice that the sink is full of dishes, then just do the dishes. Just bring the dinner. Just don't ask, what can I do?
And I think that's the difference between sympathy and empathy, right? As sympathy is, I feel bad for you. And it's well-intentioned. That's the thing, right? The whole, well, at least A, B, C, or they've got it worse than you, so you're going to be fine. It's well-intentioned in the fact that the person is trying to make you feel better. What it ends up doing, though, is often causing so much more hurt and harm than we intended that to be. And so instead, kind of coming at a place of just, this must be really hard. I got your dishes, right? Like, that I'm willing to sit in this space and I will act in whatever way I can act. But yeah, grief is grief is grief. Trauma is trauma is trauma. We don't have to compare, and in fact, comparison tends to be more harmful.
And sometimes it's, when you go over, don't have an agenda. Yeah. Don't over-plan for the person. What you've planned, hey, let's go spend the day. Well, what if they're in that space where all they can do is 10 minutes? And they're going to tell you no, because that's overwhelming. They may not want to talk to you about what's going on, but what they may need is for you to be that distraction that they need right now. And so let's talk about something completely different. Take your cue from the person. If they're in a space that they want to talk, then they'll talk. If you can hold that space with them, if they know that you're that person. But sometimes that's not what they need in that moment. And so don't go in it with an agenda.
And it could be just taking a walk and not talking.
Yeah.
There's so much healing in that too. And so when we're talking about social isolation, just being with somebody, being in the presence of someone and going on a hike or something, you don't have to be talking that whole time, and it's still healing. So that's a part of it too, is if you don't feel safe in sharing your story yet, then just go for a walk. I do have a question from the audience. And I am not sure if this is from last panel, so please let me know. What about ketamine treatments is the question. I believe that was the depression and anxiety. Okay, just curious.
Ketamine will probably make you more social too. So.
Do you have information about ketamine?
I know there's been research being done, but I'm just saying ketamine will probably make you more social.
Yes, go ahead.
Come on, folks, ask some questions.
There's several different kinds of ketamine treatment. One is transfusion, and it's done in a clinic. There also is ketamine treatment where you actually take enough to have hallucinations, and then that's followed by somebody who processes the material that comes out in the hallucinations. Unfortunately, there are some people around who do that but are not adequately prepared to really process it. So it's a way to get a ketamine high. Ketamine is a legal drug. Then there's also ketamine treatment where it's dosed and you can take a pill, a ketamine pill, and it treats anxiety and depression, I believe. I have 2 patients who are getting ketamine treatment for anxiety, and I knew they were going to start. One of them came in and I said, "You seem really different today. You're doing great." She said, "Yeah, I started my ketamine treatment." I mean, it really was just amazing. It really, but it needs to, that's prescribed by a psychiatrist or other doctors who've trained how to do it, and you need to be diagnosed specifically for the use of that. So there's a lot of treatments that are being researched right now that are, include hallucinations. They show a lot of promise, but there's a lot more research to come. No, and don't buy it from the guy in the corner.
Or, yeah, I say don't buy it from the guy in the corner either.
Within loneliness, you say, oh, well, just, talk to a friend, talk to a friend. A lot of people have a vast number of acquaintances and no friends. And in particular, if you are solo, for whatever reason, you don't have another person in your home who can kind of monitor that. So you really are by yourself. And I understand the reaching out and all of that, but I think for a lot of people, I find it very hard to find a friend. So
I think I was one of those people. I spent, of those 21 years on disability, I would say I spent 18 of them kind of always at home, staring at my 4 walls. It wasn't until my dad died that I started seeking out activity. And really, it wasn't until 2 years ago that I really put myself out there. Going to every single thing I think might be interesting that I can get to. And I had to force myself. It was really hard, but I was lonely. I do have a husband, but he works full time, and my husband is very, very introverted. He would prefer to sit in silence most of the time, and I would prefer to be talking all of the time. So it makes it difficult, and so reaching out, just forcing yourself to get involved. Go to the coffees at the library and see if you meet people. Go, and that's what I started doing. Every single thing I could get a ride to, I went to. And some of them I didn't keep going to. Some of them I'm like, okay, this one's not for me. But it helped me create what Karen called a tribe last time. After last year, I have what I consider a tribe. I have people I can rely on. I didn't for a long time, so I get it. It's really, really hard. And I think the older we get, sometimes the harder it is to meet people. We're not going to school. We may not work. We don't have all these places that are built-in places to meet people. So you have to find them.
I would also not underestimate the power of a pet companion. Any kind of pet, whatever pet you can connect with, I think a pet companion can be life-saving.
And I want to bounce off of you, because I think what I heard you say too is you kind of forced yourself to be vulnerable, and that is so hard. But I think that's part of it too. And I think, again, we can kind of blame culture and society here that we've kind of gotten less vulnerable with each other. There's an epidemic of loneliness going on. And part of that is because we don't have, we do hold ourselves back a little bit. And so I think allowing yourself to be vulnerable, allowing yourself to share those stories, I want to validate that is so hard. And that's how you can start to form some of that tribe, which is incredibly important. And yeah, go pets all the time.
What other questions do you all have?
All right, you ready for some yoga now?
Something that I've started doing is writing to my grandparents again, because we used to write back and forth when I was growing up, and I was talking to my grandpa a couple of months ago, and he was like, "Do you still have those letters?" And I said, "Yep, I've kept every one." And he said, "I'd like to start writing again." And there was something about, because we text, which his texts are pages, but There are texts, there are phone calls, but there's something to writing to each other too that we've lost the art of doing. And when I sat down to write a letter to my grandpa, it was very different from when I was 9, where I was like, I walked the dog today and went to school, and it got super, super, super deep when I wrote it this time around. And he hasn't written me back yet. So I think just like thinking about how you're connecting and also being mindful, because I'm an adult now and I like talking about deep stuff, and my grandpa's like, what is happening? But he saw it was an attempt to connect in a different way, and he really enjoyed it. It just might take him a minute to connect again with me, I guess.
Is there a place in Teller County on the websites or anywhere for teenagers to make connections with other teenagers
There's a teen
outside
center.
of school?
There's a teen center in town. And then there are a lot of, I don't know if they're into clubs, but I would recommend they look for clubs. If they like to read, there are book clubs. There's some at the library and there's some at the school. But there's also clubs at school, but there are clubs outside of school as well. And like my son, who's transgender, he got really involved with Inside Out, which is in the Springs, but it was very affirming for him. But yeah, it's hard for teens sometimes too, especially if they think they don't fit in. I was one of those kids. I was kind of nerdy, kid, and I liked to read. I didn't play sports, so finding a niche is really important.
What are their interests, if I may ask?
Our Parks and Rec is pretty robust as well. Beyond the sports teams, they do lots of, and I think it comes out quarterly, all the activities that they have going on. That's a nice place to look as well.
Finding a place for to volunteer. I know I was really, as a teenager, I liked to volunteer in an elderly home, and it was so rewarding for me. I loved it. So maybe there's something like that.
T-Crass. He can walk dogs all day. They would love that, I'm sure. So 16, plays trombone, likes animals, 4-H. Yeah, throw them out there, guys, if you have connections.
Yeah, the Ute Pass Kiwanis Club has a key club at schools. They also have a builders club and such. So those are great opportunities for kids to get involved there. And then for adults, you do have the Kiwanis Club. There's a Rotary Club. I'd be remiss if I didn't say our church and other churches in the community where you can build connections and relationships that are important, many of which have been said earlier today.
I think the problem becomes when we're isolating. The system is set up of it's all out there, but you got to go find it. And so we're working on kind of reversing that, making it easier for that person to get that connection. Just like when I say to the person, if you're offering help, you can't just offer it and then not follow up. That's kind of how our systems are set up too, is it's all out there. Now you go find what works for you. And so there's a break in our system there too when we're talking about a person in need. They're also the one that's got to go find everything that's out there.
Well, and it takes energy, right? Which is hard. That whole, objects in motion stay in motion. Well, when we're stagnant, it's that much harder to energize ourselves to go out. And so if he has a buddy, if he has a friend, and they can go do something together, borrow somebody's energy, right? Like, if we can do it together. I'm sure, I imagine there were some situations with you where you were like, well, if you can come with me,
yes,
then maybe I can stay here longer. I can try this out.
Or if your child has a teacher that they really connect with. Sometimes that teacher will let them do volunteer work in their classroom. I have a husband who's a teacher, so I'm really familiar with that. He has kids that just, like he has kids that are in their 30s that he taught years ago who still stay in touch with us, you know, because he would open his classroom at lunchtime and they would, you know, play chess or something the kid liked. So.
There is also a mention over here that the Teller Senior Coalition does provide rides.
The coalition is a real blessing here in Teller County, and they have no restrictions. I volunteer a lot at the Senior Center, which is another place that I've seen lonely people come in, and they like to play dominoes, or they just like to sit and have coffee. But there's several people that love to come in, and they can call the coalition, and the coalition will pick them up, and then bingo, then they take them home. But the coalition is wonderful if you cannot get out. They'll take you to doctor's appointments in the Springs. And shopping. They have a little van that they go around once a week and go to City Market, and you can get out.
Thank you.
Oh, also the Senior Center, which to me you see so many lonely people that aren't lonely anymore. And we have twice a month or maybe once trips, like once, every so often they go up to Cripple Creek to go to the melodrama. And that gets them out. Or we went leaf peeping. Or you go to the planetarium up at the Air Force Academy. But that is a wonderful, wonderful place if you're looking for
Christmas lights. Christmas lights.
Christmas?
Yeah.
She's going to have
This isn't for kids, but it's adults, so it's all ages. The Ute Pass Social Club. Now, I have to admit, when I first moved here, I said, "Oh, well, what's that all about?" And the person said, "Oh, it's bingo and games, and it just sounded like an old biddy club." And I went, "Oh, no, not for me. I'm not there yet." But they hike. They've got multiple layers of hiking. They do a whole variety of things. So if someone asks, it's not an old biddy club. It actually has a whole lot of a variety of things. So.
Where is that?
Into the club? No. You do not need to be invited. Now, it's a minimal amount of like $10 or something like to join, but they don't kick you out if you don't join. You know.
Where do you meet?
A variety of places. Like Wednesday, there's a yoga class here on Wednesday mornings. Thursday's the longer hike. Friday's a shorter hike. You just basically have to get on.
Well, how do you find it?
Go online to the Ute Pass social club, and they have a newsletter, and they bring out all sorts of wonderful things. So.
Thank you.
Look it up.
Look it up. Google it.
I'm actually an officer in the social club. I'm the treasurer. So if anybody has questions about how to join, let me know. I'm here. Diane Browning. Yeah, I'm an officer of the social club, so if anybody's interested, let me know. And you can find us online. There's not a whole lot of stuff on the web page, but there is enough information to download the membership forms and some contact info for our membership person, who's Marianne Schroeder, if anybody knows her. But there's enough information to download the forms or some contact information if you want to call anybody and ask questions. But she did a very nice job of summarizing. We have all kinds of activities, and we have a monthly luncheon. It's always the third Tuesday, or almost always the third Tuesday. And sometimes it's up here in Woodland Park, sometimes it's down in Springs, depends on who we can get to accommodate a big group. We usually have 30 to 40 at the lunch every month. And then there's bunko, and there's Mexican train, and there's mahjong, which is a great exercise for your brain if you're interested in that. So there's all kind of stuff that we do. So if anybody's interested, just let me know.
Okay, well, thank you, panelists, for your time. If you could give them a round of applause again one more time. Thank you. I just really wanted to, I know there's probably a break right now. Let me check. If it's okay, can I go through this in like 5 minutes and then do cookies? Cool. When we're talking about availability of resources in Teller County, something that the Teller County Mental Health Alliance has done is create a website for Teller County specifically. So if you are needing resources and you don't know where to start, this is a great place to start. On the front page, what you see up here is 3 buttons. So how to get help now, resources, so there's a resource navigation page, and it kind of gives some background about the Teller County Mental Health Alliance. So the website is www.tcmha.org. Could you go to the next slide, please? And also on the front page, there's some detailed information about what happens if you call 911 for a mental health emergency. Often when we're in crisis and we're going to call 911 for a mental health emergency, we don't know what's going to happen when we do. We don't know what questions we're going to get asked. We're running in our minds like, I don't know what's going on. And so this will walk you through what happens, what that process looks like, the questions that they ask when you call 911 for the MAPS team. There's also detailed information about the Colorado Crisis Line and what to expect if you were to call the Colorado Crisis Line. If you're dialing 911, you are requesting services for somebody to respond to your home, okay, or wherever you are. If you're calling the crisis line, it's if you need to talk to someone or connection to resources. If they do, with conversation with you, if the operator is sensing that you need somebody to respond to your home, they will dispatch to the MAPS team anyway. So just know that that's an option either way. But if you are trying to help somebody else who's in crisis and they don't feel comfortable calling the crisis line or calling 911, you can go to this page and kind of walk through with them what that will look like. And it's also really helpful if you're with them to make the call or making the call for them. Next slide, please, just really quick. And then this is just a snapshot of the resource directory. And so you will have the opportunity to choose your location, your insurance, your what kind of services that you're looking for, like care coordination, food, housing, transportation, substance use, therapy, counseling, whatever it is. Hopefully it's on there. And it will only show what you check off as what you need. So you're not gonna have to Google anything and try to navigate all of those things. You can do it all in one place here. So I just wanted to show that to you all. So when you leave here today, just know that it's a resource for you because it was a heavy day. Hopefully it was an uplifting day too, and that you're leaving with tools and conversation starters for maybe people that you care about. I know I always have someone I'd like to check in with, and this is a reminder of that. And looking at the next thing, I'm going to say let's take a break, and then I'm going to go check in with Tiny to see what's next for him. And I will see you back here in 5 minutes. Thank you. Actually, it's not 5 minutes, it's 15. All right, guys, I'm going to introduce James McLaughlin again. He was a part of our Adverse Childhood Experiences panel and did a wonderful job introducing our keynote speakers from the Behavioral Health Administration. But I just wanted to introduce him again and thank him so much for his support with all things behavioral health in Teller County, but also to bringing the community together. And you're so well spoken, and your energy is what we all need, especially this time of day.
All right, it's the end of the day. We made it to the end, everybody. How about a round of applause for Ashley? I will tell you, it is very, very hard to chair, 4 panels today? 5 panels? 4 panels. That takes a lot of mental energy. So please take care of yourself tonight. Do something to reward yourself. You deserve it. Next, I want to give, can I get the members of the panel that help, the board that helped set this up today? I know you guys have a title, and I'm sorry I can't remember it. The Adult Education Committee. Can I get the members of the Adult Education Committee to stand up real quick? Guys, let's give them a round of applause. Here's the thing about that. What they did was they did something that hadn't been done here before. They opened themselves up and made themselves vulnerable and made the entire congregation vulnerable, but there's something that hadn't been done before, right? Stigma around mental illness, as we know, stigma around mental illness and substance use disorder is a leading contributing factor to why people don't reach out for help or go for help. Programs like this, they reduce that stigma. Because of the work that you guys did over the last several months, you're taking a huge step in letting your community know that it's okay to not be okay. And we got you. I'm there for you, brother. Sister, we care about you. And that means so much. And if we continue to do this, then someday mental illness will be looked at no different than heart disease, no different than high blood pressure, no different than cancer, right? And that is when we will know that we've won the battle, and that's when lives will truly start to be saved. So thank you guys for that. Thank you so much from the bottom of my heart, because that is a mission that's near and dear to my heart. And you guys trusted Ashley and you trusted me enough to bring us in and to help you just a little bit with what you guys accomplished today. So that's incredible. I want to talk real quick about, I know Ashley talked a bunch about behavioral crisis. So I'm not gonna rehash the 988 or the 911 or if you need help, call a number. If you don't know who to call, our program takes a no wrong door approach. Just call, they will figure it out, and we will show up. Okay? It's the MAP program, Mental Health Assessment Program. And if the person's unsafe for us to approach directly, then a lot of our providers have been trained in FBI, crisis, and hostage negotiation, and they will not just a little bit. They're not dabbling their toes in it. They're certified level 1, level 2, and level 3, and they've sat for the certification test. They know crisis negotiation inside out, upside down, and backwards. And they will take those knowledge, skills, and abilities to talk to that person indirectly, to engage with them through social media, through whatever means it takes to let them know that there's somebody on the other end that cares enough about them to give them the time, effort, and energy that they deserve just because they're a person, just because they're a child of God, and for no other reason. So, all that to say, we are honored to serve this community. This community paramedic program is not ours, it's yours. You own us. We are completely open. If you ever want to come in, see more, learn more, our vehicles, if you want to go through our vehicles and learn more about what we do, we will do that at any time. If you have a group that you want us to come and speak with, we'll do that. We want to eliminate not only the stigma, but we want to eliminate the unknown, right? We want to make ourselves so well known that you're just tired of hearing about us. Because then that makes it less scary. That makes it more normal. And that's what we want. We want to be your friend. We want to be your neighbor. We want to be your resource. Because we are your ambulance and we are your community paramedics. All we are stewards of what you've entrusted us with. And I thank you for that. Sir, if I can bring you back up. And it started at the beginning of the day with you handing me the microphone. Big mistake, by the way. No, you handed me the microphone, and now I want to make sure that I turn this podium and this microphone back over to you, Michael. And thank you so much for everything.
Thanks so much, James.
Absolutely, brother.
Well, thank you very much for attending today's symposium. I hope you learned as much as I did. I'd like to thank all our panel members and support volunteers for sharing their expertise and experiences today. The folks from the BHA, the state agency, who made the time to come down and speak to us. Also thanks to Lori Jones, Tim Rucker, Sandy Rucker, and Marcy Nicholsberg for all the logistical support that made today possible. Sandy put the binders together that you have and also made sure that the microphones were working and the YouTube broadcast was going on, so she really put in a lot. Thanks to all the ladies that served us lunch and cookies. And I'd like to thank the three people who organized this symposium. Fred Tinsley, our chair of our Adult Education Committee. James McLaughlin. And Ashley Shields. We on the Adult Ed Committee kind of had this vague notion of hosting a mental health symposium, and we came to James and Ashley, and they really kind of did all the hard work of figuring out, okay, these are the panel topics, these are the people to be on the panels, and lined up the panel participants. So we definitely couldn't have done it without these two. And if you haven't already done so, check out the tables that are out there, the organizations that are handing out materials. Oh, you missed your opportunity on that, apparently. So thank you again for attending today, and safe travels on your way home. Thank you so much.